What is the reason of asking this thyroid disorders particularly?
Sir, if the patient has had previous thyroid surgeries, this could be a recurrence from that, firstly.
Okay.
Can I ask Ravi one question? Is about
Yes,
radiation. I know you have asked a relevant. Why history of radiation is relevant in neck swellings?
Sir, if the patient has had exposure to radiation in the past 10 years, with an incubation period of 10 years, patient is prone for
Correct.
Patient is prone for lymphoma and thyroid malignancy like papillary thyroid carcinoma.
I agree with you, doctor. Well, what is the age of this patient?
45-year-old.
45 years. So at the age of 30 or 25 to 30, what radiation, what diseases can you expect radiation as a treatment?
So at that age, when she was 20 years old, 10, 15 years old.
Lymphoma itself, for dermatological disorders.
Yeah. More of dermatology, because for lymphoma, do you think what stage, what are then the question will go in a different way. You see, when you mention lymphoma, what particular indications for radiation at this present day for radiation for in lymphoma? So let us not go into that. I think we'll go ahead with other questions. There are other examiners who can ask their
Manya, at this stage, what did you have in mind when this type of a lady comes to your clinic with the swelling somewhere on the lateral side of the neck? What did you have in mind firstly?
So given the progression in size, I would look into either tubercular or malignancy.
No, I didn't ask you the etiology. I thought what probably is the swelling. First question.
I would think it's lymph node, sir. She's 45-year-old.
Very good. So that is how the progress of your reading question should come. Unnecessarily don't get into the trouble of irradiation in this patient, etc. So you considered as a lymph node swelling.
Yes, sir.
That is the most common swelling in the neck. Now, nextly, what do you think the common surgical lymph node swellings you encounter in your wards? Usually.
In India, it's tuberculosis.
Irrespective of India or anywhere, what is the common thing? What you see encounter is a metastasis. You have the lymph, tuberculosis. I agree with you. So if you keep that in mind, what are the leading questions? In your case, with this history, what did you think now at the end of the history? I will not repeat the same question. So
at the end of history, because I don't get any replies leading to suggestive of tuberculosis, I would look into secondaries of neck with
what is that it may lead to tuberculosis according to you?
Sir, loss of appetite, loss of weight, cough, then evening rise of temperature, chills, fever.
No, don't go on telling everything. Lymph nodal tuberculosis is primary or secondary?
So secondary, sir.
No. Lymph nodal tuberculosis is primary. So you will not get all that cough. Not that you can't have, but I'm just telling you generally. So yes, evening rise of temperature, how commonly it is found? Is it mandatory? If it is present, it will help you. If it is not present, does not rule out. Okay. Now, loss of appetite or weight, you are told. What made you to think of malignancy? Malignancy means what did you have in mind?
Draining areas for that oral cavity or malignancy of upper.
No, your answer should be, when I ask you the question, what did you have malignancy? Say, sir, metastasis. Then the examiner will ask you, where do you think the probable primaries? Where do you suspect in your patient?
Upper aerodigestive tract.
This is how you. So, do you have any clue? Do you have any clue? In the
site of the swelling.
Any symptoms pertaining to that?
Any symptoms?
No, sir.
Nothing. So you have no clues at all about that. So now then what is the other thing remaining now for you? Okay, I think
so she's a tobacco chewer. So.
That does not mean that patient is having a aerodigestive malignancy. Okay, but yes, We have to keep it in mind, back of the mind. Sir, other examiners, please take us.
Yeah, we should progress to the clinical examination.
So patient is examined with due consent with adequate exposure in a well-lit room. She is conscious, cooperative, and well-oriented. She is moderately built and poorly nourished with a BMI of 18.1 kg per meter square. Her pulse rate is 88 per minute in right radial artery, and BP is 130 by 80 millimeters of mercury in right brachial artery. Her respiratory rate is 18 cycles per minute. ECOG performance score is 0. Pallor is present. There are no signs of icterus, clubbing, cyanosis, generalized lymphadenopathy, or edema. On inspection of the swelling, we see it extends till anterior border of trapezius posteriorly to 3 centimeters anterior to sternocleidomastoid anteriorly, from the lower border of mandible to 10 centimeters from mastoid inferiorly. It measures around 7 into 5 centimeters in maximum horizontal and vertical dimensions. It has a smooth surface, and skin over the swelling has 12 to 15 superficial burn marks and healed scars. There's another globular swelling noted in the right posterior triangle, measuring about 1 into 1 centimeters with smooth surface and defined edges. We don't see any sinuses, fistula, or other swellings. No supraclavicular fullness, no engorged veins or visible pulsations over the swelling. On palpation, it is non-tender with no local rise of temperature. The swelling measures 7 into 6 centimeters in maximum vertical and horizontal dimension. It extends superiorly 1 centimeter above the angle of mandible, inferiorly to 5 centimeters above clavicle, anteriorly 3 centimeters anterior to sternocleidomastoid, and posteriorly 4 centimeters anterior to trapezius. All the margins are well defined. The swelling is hard in consistency. It has a nodular surface. It is non-mobile, it is fixed. The skin over the swelling is pinchable. So the plane of the swelling is deep to deep fascia and superficial to sternocleidomastoid. There is another discrete enlarged lymph node in the posterior triangle measuring around 2 into 2 centimeters. It is non-tender, hard, and non-mobile. We further continue examination of nose and nasopharynx. Nasal cavity is examined. We see the turbinates and nasopharynx posterior wall.
I think you could have stopped at this stage before you go to the indirect laryngoscopy or a video.
I think so. I think so. The question should come from us. What would be the, yeah. Anyway, let us have a discussion now. Rajgopal.
Yeah, Manya, no?
Yes,
Just show me that swelling again. You said over the angle of the mandible 1 centimeter. Just show me that again. Where exactly? Can you show it with the cursor exactly? Which one you are referring to?
I do, over the angle of mandible 1 centimeter above, sir.
Where is
Near her ear lobe.
You're not put that photo.
And where is the lymph node which you are referring to? Which one are the lymph nodes? Can you show it again?
The whole thing is a single
From
mass.
where? Just show me exactly.
Sir, actually, I'm Nishant. I'm handling the system. So
Yeah.
she doesn't
Be
have
having
access.
the control over the cursor, sir.
Okay, no problem, no problem. I just little clarification I wanted, because I just for the PGs, it is, since there is a mention about over the angle of the mandible 1 centimeter means no cervical node will go up like that. It is that is why whether something else has to come in the mind.
Manya, let me
Yes.
intervene. Did you mean that the upper border of the mass is, or the swelling is 1 centimeter above the angle of the mandible?
Yes,
Is that
sir.
what you wanted?
Yes, sir.
Yeah, I think you need to be clear. You know, you should understand. We expect the examiner who is sitting away from the patient should be able to imagine what you are describing the swelling. You understand? even
Yes, sir.
without seeing the patient. So that should be referring to the anatomical landmarks and also proper terminology. You should say the upper border of the swelling is above 1 centimeter above the angle of the mandible. So like that you should mention. I think your description was not giving that much information. That's why the confusion.
I will ask you one question, Manya, because of the time. You said on contraction of the sternomastoid, that swelling became more prominent, correct?
Yes, sir.
No,
That
no,
means
sir.
that
He said
what
it is
is
less
that
prominent.
means that what is that swelling? First
Yeah.
question.
Sir, it is present superficial. It should be a lymph node, sir.
Do you think lymph node is superficial to sternomastoid? That is why I'm asking you, since we are away, but description, two things here. One, you are telling it is above the angle of the mandible 1 centimeter. Second, you are telling it is superficial to the sternomastoid. I keep actually that way parroted in my mind.
Absolutely.
With your description, I am not sure about, I mean, your description, and I know the rest of the things is a nodal mass. Anyway, other
No, Manya, I want to know, do you have any picture of what happens to the swelling after contraction of the sternomastoid? Have you got
I
a
don't
picture?
have,
No.
sir.
Yeah. I think there is a slight confusion about what happens is when a large lymph node mass which is overlapped by sternomastoid, when it is put to contraction, the part which is not overlapped becomes more prominent because it gets compressed and the swelling can be pushed partly or whatever is the reason. So I think that's what you are getting confused for. That is my opinion. But anyway, in the exam, this cannot be taken for that description. You have to accept, once having committed, it is prominent, you have to take it as superficial to the sternomastoid. You have lost the discussion at that particular time.
Okay,
Dr. Siddesh is absolutely right. Please note that when you have a
Yes, sir.
large swelling of and a very thin neck with the thin sternomastoid, it's difficult to elicit the correct interpretation of the sign. The muscle may contract, make one or the other part of the swelling more prominent, making it clinically interpreted as being superficial. You have large swelling in that area for the plane of the swelling.
Adding on to Dr. whatever Rajan sir told, one is whenever such a large swelling, difficult to comment on the plane, and extremely be careful about lymph node overriding the mandible and going above 1 centimeter. You should be a little careful about it. That means this is a classical situation, happens differentiation between the lower pole of the parotid versus a angle lymph node at the angle. Just for the sake of postgraduates, I am telling you, be careful just to find any groove between the mandible and the swelling. You need to find out here. Yes.
I just want to add one word here, that general information to all postgraduates, take it from me today. The lymph node mass which is kept in exam will not be superficial lymph node. It will be a deep lymph node to become pathological. I don't think anybody will have a superficial lymph node unless there is another swelling which is more kept as a primary swelling. So don't go by the superficial lymph node as a description in your exam. It's the general information.
Can we move on?
Yes.
One more important sign is there in your picture. Can you make it out? You've given the description of the mass. So there's one more important sign is there in the inspector findings.
Platysma, anything? Correct, sir? You wanted that?
Okay.
There is platysma sign. You could see the platysma stands prominent. What it indicates?
Yes, sir.
What it indicates? What is the importance of that platysma sign?
Manya, if you don't know, please say don't know, then we can move on.
Ishwar, you give the answer, Ishwar.
Yes. Yeah, it shows the infiltration. The tumor is almost infiltrating to even up to the platysma. Then one more important sign, you already said that skin is not pinchable. If the skin is not pinchable by all practical purposes, probably platysma is infiltrated. But there is one more additional sign is there below that. It gives more information. In the inspection only, you can make out tumor is infiltrated to the skin. Skin is pinchable is under palpatory finding.
Okay.
And Manya, just for the sake of completion, don't mention no scar, no sinuses, and no fistula. Your case is a your case, lymphatic.
So for the sake of postgraduates, all lymph nodes swelling in the neck is always deep to deep fascia. So
Yes.
you do not make any lymph node as superficial to deep fascia because there is no lymph node in the superficial to deep fascia. So postgraduates, please be aware of this fact. Okay, continue, ma.
There are few lymph nodes are there superficial.
Yeah,
They're
they're
called external
Not,
jugular,
yes.
submental. They are superficial, but they are not very important for the examination
Yeah.
point of
Yeah.
view.
Proceed, Dr. Manya.
Sir, I will further continue my examination of nose, nasopharynx, and oral cavity.
Go ahead. Go ahead.
We notice multiple dental caries, no oral ulcer or pre-malignant lesions, no lesions tongue. On palpation, lesions are felt. The mass is not bidigitally palpable. On laryngoscopy, here we see the uvula, base of tongue, epiglottis, the two valvula, vocal cords.
So use the word video
laryngoscopy.
Okay. Yes. Nowadays, don't mention indirect laryngoscopy, usually video laryngoscopy. Yes.
Yes, sir. Then on systemic examination, CVS, S1, S2 heard, respiratory system, bilateral normal vesicular breaths also heard. Per abdomen, the soft, non-tender, no organomegaly, no mass per abdomen. Then on central nervous examination, no focal neurological deficits. Here I'll give a diagnosis of enlarged matted submandibular and cervical lymph nodes, with the first possibility being secondaries in neck with unknown primary, and second possibility being tuberculosis.
Manya, so justify your the choice of diagnosis. Why did you put secondaries first compared to tuberculosis?
We are left with 10 minutes, sir.
Yeah.
Sir, in the laryngoscopy, video laryngoscopy, we saw fullness on the right side, sir.
No.
Side of.
See, I don't think laryngoscopy is part of the clinical examination. So don't confuse the issue. You have made a clinical diagnosis. First, you said the first diagnosis is secondary, second is tuberculosis. You have to clinically justify. We'll go to the investigations later.
Yes, sir. Given her age, middle-aged, along with history of tobacco chewing, I'll suspect a malignancy. And
okay. What clinical findings made you to go for malignancy as opposed to tuberculosis?
So the lymph node was hard, sir.
Okay.
Then that's also.
See, some more findings goes more in favor of.
Quickly, you have to tell Manya that she's this mature lady, chronic tobacco chewer. That should come in your mind first. Rapidly growing, hard, indurated, almost fixed mass with the skin infiltration with platysma sign. So I suspect. Over.
Yes, sir.
I'm not sure whether, sorry, little faster. Did you mention about any nerve paralysis in this patient? Not neurological examination, not central nervous. Any nerves specifically did you mention in this patient? You should mention.
Which are the nerves you expect at that area?
Yes.
If at all they're infiltrated, producing some signs.
Sir, marginal mandibular branch of facial nerve.
Submandibular large mass. What is that nerve comes there the
Submandibular,
submandibular
what is
triangle.
Lingual.
You have both there, hypoglossal
Lingual.
as well as lingual.
Hypoglossal, that is what they were expecting.
Yes, sir.
Okay, now how will you progress to investigating this patient? Any
Sir,
other
I'll-
questions? Yeah.
No.
With this signs you have mentioned a sign. So why you kept the second possibility tuberculosis?
So given the site of the lymph node, so it's not a part of generalized lymphadenopathy. It is localized.
See, one thing I'll tell you, it is very rare to skin to be involved in tuberculosis. If at all involved, there will always have a sinus, one thing. And second thing, platyspinal will never be there in tuberculosis. Okay.
Yes.
And then they will not attain a single large of this much size, very unusual, unless it is the hypertrophic variety, then only they will have a very larger size. Usually they are a discrete group of lymph nodes. It is a matted group of lymph nodes in the upper deep cervical with immobility almost fixed. Then it is hard in consistency, but there is no need to put for the tuberculosis as a second differential diagnosis. Unless examiners ask what are the other possibilities would you like to consider. So since the India is quite common, sir, I thought of it, but some of the findings are not in favor of tuberculosis. That's what you have to justify.
I fully agree with Dr. Ishwar Vasmani, whatever told. Something similar also happens in the breast with the typical lesions like that. Pucker, nipple retraction, purity orange, axilla nodes. What is the no differential diagnosis? Straight away you can tell. All right. Yes.
Yes.
Investigations.
Sir, I'll get an FNSE of the swelling, sir.
In this, you are supposed to check the functions pertaining to the lingual node and hypoglossal node when you part the examination of the oral cavity, because it is a hard, large, fixed in the area of hypoglossal and lingual nerve. Whenever examination of the oral cavity, clinically, you need to look for the movements of the tongue and the palate and other things. Look for the hypoglossal nerve function and the lingual nerve function. These are mandatory in this case. Am I right, sir? Should I say?
Yes, sir. Because all the postgraduates here should know just by sentence no F, and she mentioned some no focal neurological deficit, no FND. No, that is not acceptable in your case. No. In your case, what is acceptable is specific mention about the nerves, 3 nerves, and little lower down means Horner syndrome, cervical sympathetic system. It should be a common methodology of examination. Yes.
Ask her now, how will you clinically make a diagnosis of hypoglossal pulse?
Sir, deviation of tongue to the same side, or if it's long-term, wasting of tongue muscles.
Yes.
Okay.
Okay, I think that's correct.
So what is the video laryngoscopy finding? What is the finding?
So we saw fullness in the oropharynx in the right side, sir.
Then why you kept as unknown primary then? If you have seen, if you got a positive findings in the video laryngoscopy, then what did you put as unknown primary? If video laryngoscopy is a normal, then you have to mention that it is unknown primary.
There was no mucosal lesion as such. Only fullness was noted. There was no mucosal lesion. So
fullness can be due to pressure effect. You should have looked into the nasopharynx sinuses also. Until we have the imaging reports, we don't stamp anything as MUO or metastasis of unknown origin.
Only
I think no, Dr. Venkat, what she said was that
there is a fullness on the left side of the vocal cord.
See, I think broadly, secondaries in the neck with the known primary, it is very clear. In spite of investigation, nothing is found. Then you say occult. Then this is in between. What you can only use the word is clinically unidentifiable primary. Clinically.
correct.
This is a better word. Sir. Yes.
Primary under evaluation.
Yes, this is how it is broadly classified. So.
Okay.
That is unknown word itself is an indication to go for examination. If you have mentioned about that, there is no need for that. The moment you mentioned that is unknown primary, clinically you have not found it. So you need to investigate those areas by laryngoscopy and other purposes.
Correct.
Clinically, you are right. What you put it as unknown primary.
So the students need to note that in the examination, even when you write your findings, please do not use non-recognizable, non-recognized short forms, because I think the examiners will not take kindly to that. So please do not use it. Okay. So investigations, you said FNAC. So what do you expect in the FNAC? Is it conclusive FNAC?
We will know between the two differential diagnoses if it is malignancy or tubercular. If it's granulomatous, we can get to know.
Madam, in your case, harp on only malignancy. Today, I want to know differentiated carcinoma, undifferentiated carcinoma, well-differentiated carcinoma, or adenocarcinoma. That is what I expect the answer from you, not to differentiate tuberculosis. Suppose the histology comes as adenocarcinoma, what is your comments in your patient? This is level 2. I am giving you a clue.
No, but she is talking about FNA, no? FNA. Is she talking about core needle or FNA? FNA. Can you get so much of information, Dr. Rajgopal?
You can mention adenocarcinoma. You can.
No, but I will tell you. I want to ask her. In an FNAC, if it is a malignancy, what is the information regarding the cells you get? I think
we will know the pleomorphism if it's normal or metastatic, sir. I mean malignant, sir.
No.
Like MC ratio of each cell and mitotic figures.
Manya, there is a question from in the chat box. Will you do non-invasive investigation before non-invasive investigation?
No, so first I'll want an ultrasound and then FNAC.
No, and a CT probably, because CT will give you good information, or even if you want to know about the bone, I think MR is better. So those 3 investigations, in that order, you have to first do that, then get information about the size, the extent of the lesion, the nature of the lesion, where, and then, and depending on that, then you can target your FNAC to the most probable area from which you can attain the diagnosis. So invasive investigation should come later, as opposed to the other, because you may also,
FNAC is a simple procedure, can be done in the OPD.
Yes,
I
of
think
course.
Should be accepted. If FNAC shows tuberculosis, why would you want to do so many extensions?
Sure. No, but this is not tuberculosis as we have seen.
So FNAC first is accepted.
I think let us not get into controversy here. I think FNAC is an accepted mode of primary investigation. It is sometimes considered as like ultrasound and FNAC are complementary to each other. They can be told in the same breath. And I think the advantage of doing an ultrasound before FNAC is you can avoid, number 1, a vascular structure. Number 2, you can direct your FNAC to a representative area of the mass. So these are the 2 advantages the PGs should be able to.
This is what I exactly meant. You target
right.
your.
But
target
CT,
your,
no, sir.
CT and MRI probably no. I think Dr. Siddesh, what
even Arun is also agreeing with that.
Yes.
Yeah, but my question is on the FNAC. Rajgopal is asking about how to differentiate between different types of malignancy, accepting that pleomorphism will be there, hyperchromatism will be there, so loss of polarity is there. Agree, malignancy. But what is looking at the cell? Can you pinpoint to any particular malignancy? Can you tell me?
Siddesh, what I wanted is FNAC can tell. My question was whether you can diagnose adenocarcinoma.
Same thing I'm asking.
So you can diagnose adenocarcinoma. So that shows it may be a malignant salivary gland tumor in your case. That's what I wanted to answer. Why FNAC will guide towards the investigations. When in doubt, yes, such a large tumor, you can do a true cut also. I think let us not go to the.
I request the moderators to conclude.
Summary for this is
Harish, let one of the senior faculty summarize how to go about this case and how to manage this case in 4 to 5 minutes.
Yes, sir. It's already time up.
After that.
Yeah, it's a time up.
One of the senior faculty, please.
No, Arun has not spoken so far. Let him have the chance of talking. Arun?
Yeah. So in this case, probably as we know, malignancy, secondary malignancy will be the first option for the diagnosis, and an ultrasound and FNAC. Before that, of course, the indirect laryngoscopy, video laryngoscopy, and then followed by the ultrasound and FNAC would be the choice. and depending on that, the treatment has to proceed from here on. So it is a lymph nodal mass, probably malignancy, video laryngoscopy, ultrasound, and ultrasound guided FNAC.
Yeah. Please
Just
don't forget to look at the nasopharynx also. Probably you need to have that also mentioned as one of the sites in which you get the notes. The important thing is that the FNAC gives us the direction towards where we are likely to go. You can definitely make out primary versus secondary malignancy on FNAC. In secondary malignancy, we can make out between squamous and adenocarcinomas, and that leads us to further investigation. The high degree of the tumor and in this malignant and nature of the tumor is better assessed on through-cut biopsies. Thank you.
Sir, I will add only one point. Manya, in this case, if the second diagnosis is asked to me, I would have put it as malignant submandibular salivary gland tumor. That is my second diagnosis. Not tuberculosis, not lymphoma. That's all. Thank you.
Does Manya have
One
any
more addition to
questions for
that,
the faculty?
One more addition to that, if the similar tumor is there in the lower part of the neck, if it comes as adenocarcinoma, we need to keep the possibility of a lung disease. Upper part of the lobe of the lung has to keep in your mind. Majority of them are squamous cell carcinoma, but to our surprise, many times we can get an adenocarcinoma. If adenocarcinoma coming from the upper part of the neck, as sir said, Shana says that it has to be always a salivary gland tumors. If it is the lower part of the neck, you need to keep the possibility of a lung as a primary disease, particularly wart cell carcinoma, small cell carcinoma. They are adenocarcinoma. In those cases, it will be invariably presented to the Horrocks syndrome most of the time.
Ishwar sir, thank you. Manya, do you want to ask faculty anything? Do you have something doubtful
Any questions?
in this case? Any questions from Manya?
Feel free to ask. Don't worry.
Please, that way, yeah.
Sir, what is the role of MRI in this patient, sir?
You are talking about MRI as a part of investigations. If you are doing a surgery to know the skull base, especially skull base, high up lesions, large nodal mass, fixed mass. So MRI definitely has a role. I'm not trying to say that if you have got the facilities to know the soft tissue invasion.
If your indication for removal of the lymph node mass is there, then you need to know the relationship of the neurological bundles. You need to vascular neurological bundle, because soft tissue gets better delineated on MRI relationships. So, but today we have very high quality CT scans. They may be complementary as well. So it is only relative.
For a skull-based involvement, the CT has got a better choice than MRI. The soft tissue delineation is MRI is better, particularly when you're expecting nerve is involved. So bony canals are widened, all these things can be better made.
But Manya, my final conclusion is your clinical assessment is primarily important. All examiners will be looking up to your clinical approach to this lymph node mass. Investigations, everybody will answer. I think it is only the clinical approach we will be testing you. Be careful about that.
Yes, sir.
Thank you, sir. Thank you, Dr.
When you have final question, answer is that when you have a platysma sign positive, please don't miss it and just hang on to malignancy as your diagnosis. Take tuberculosis out of the picture. Thank you.
Good presentation.
I think Nishant can go for the second presentation. And meanwhile, any recent advances can put it in the chat box. Any questions regarding this first case, you can the questions and answers can be discussed in the chat box. Thank you. Nishant, second case.
Yeah, Dr. Sonika.
Thank you, sir.
You have 30 minutes, Sonika, 15 minutes for presentation and 15 minutes for management, diagnosis. I mean, the evaluation and management.
Yes, sir. Thank you, sir. Good evening, dear teachers. Myself, Dr. Sonika. Today, I'll be presenting a case of CA thyroid. Next slide. Here is a 63-year-old female patient hailing from Saudatti, Belgaum. She presented with complaints of left-sided scalp swelling since 6 months. The patient is apparently normal 6 months back. Then she noticed a swelling over the left side of the scalp, which was insidious in onset and was initially approximately of size 1 × 1 centimeters, and it has progressed to the attain the current size of 6 × 8 centimeters. And the swelling is not. The swelling is not associated with pain. There is no history of discharge or any wound over the swelling. No history of headache, vomiting, or seizures. No history of any other swellings elsewhere in the scalp or in the body. No history of trauma, and no history of regression of the swelling. Next slide. Past history, the patient has no comorbidities. Personal history, patient consumes mixed diet, sleep and appetite is normal, bowel bladder habits are regular and normal, no addictive habits. Next. Family history, no history of similar complaints in the family, nor any history of cancer-related deaths in the family. The patient has attained menopause 20 years back. Coming to the general physical examination. So should I continue?
I think you stop here and let the examiners ask
Yes.
you any questions in terms of the history. The first suggestion I would make is do not put up your slide saying that this is a case of thyroid, carcinoma thyroid, because you don't want to be starting with that. You should say swelling in the scalp or neck, whatever it is. And when we come to the conclusion, you can conclude whatever you want, but you don't start off with saying, I'm presenting a case of carcinoma thyroid.
Okay, sir.
Okay, examiners, Dr. Rajan, sir.
No, exactly what Ravi has said is absolutely right. It should be presented as a scalp swelling rather than as carcinoma thyroid. Okay.
Manya, can you name some commonly rapidly growing scalp swellings? Other than your case. Okay. Tell me.
See, Sonika,
Rapidly growing, sir.
Rapidly growing scalp swelling. Other than what your case. Yes, just quickly, so that we'll get some idea whether you know broadly you have read. Yes.
Ganesh, sir, she is Sonika, not Manya.
Oh, sorry, Sonika.
Yes, sir.
Okay.
Sir, hemangioma, sir, in the hemangioma.
Is it a common sight in the scalp to get a hemangioma or something?
No, sir, unlikely, sir. But secondaries in the scalp are fast.
Yes. So I wanted.
Vascular swelling still persisting with any particular vascular swelling, Dr. Shanai would like to know. Any other vascular swelling other than hemangioma?
And any
you said metastasis. Your case, we know your diagnosis, but any other tumors also can spread to the scalp and grow rapidly. That is what is my first question to you. Come on.
Melanoma, sir.
Melanoma, she will have some source, somewhere it is in. What I wanted is quickly RCC, renal cell carcinoma. You need to keep it in mind always.
Yes.
Understand?
Yes.
Your case, we know thyroid, but RCC to be kept in mind. And 2 causes in men. I have given the clue to you. Men.
Prostatic cancer, sir.
Yes, definitely.
And CA colon as well. Could.
Not CA colon.
Like
not
that,
colon.
all
Testicular tumors, sir. Testicular tumors and prostatic cancers.
Testicular tumor doesn't go to scalp, ma. It can have cerebral metastasis and cannonball metastasis, but not scalp metastasis.
What renal cell carcinoma is for both. Okay. You understand? Bronchogenic is definitely more for men. Bronchogenic can give rise to, and prostate definitely yes. Breast you should not forget in a female. Understand?
Yes,
breast and thyroid. So that is one. So what is turban tumor? Quickly. Turban also can grow rapidly like that. Heard of that?
Turban tumor.
You know all these adnexial tumors and all those.
Yes, sir.
I think quickly read about that.
Tricky level, yes, sir. Yes, sir. They arise from the appendages of the skin, sir. That can also have rapid growth.
For your information, it is cylindroma. Turban tumor. Okay.
Okay, sir.
Any skin-related structures can produce a tumor there?
So BCCs and squamous cell carcinomas can
produce
arise.
ulcer. Rarely they produce swelling. They produce ulcer.
Ulceration.
Acrine and apocrine and acrine line tumors from the skin adnexal tumors can be more common in the scalp. Skin adnexal tumors.
Okay, we can proceed.
Continue the clinic examination.
Yes, sir. General physical examination. An elderly female patient is moderately built and nourished, well-oriented to time, place, and person. Her BMI is 24 kgs per meter square. Pulse rate is 88 beats per minute. Regular rhythm, normal volume, measured in the right radial artery. BP is 130 by 80 millimeters of mercury, measured in the right brachial artery in supine position. Respiratory rate is 19 cycles per minute. Patient is afebrile. There is no pallor, icterus, cyanosis, clubbing, or edema. In the head-to-toe examination, a solitary swelling was noted in the front of the neck, which moves with deglutition.
I think that line is suddenly looking little between your general examination and the swelling.
Yes, sir, it was a part of the head-to-toe examination, sir. That's why I noted.
I don't know. I think you should not come at this stage now.
Sir, the reason being is that patient is never aware about the thyroid swelling. She presented with only scalp swelling. During the routine examination, we could be able to find that there is a neck swelling. That's what we have put it exactly the examination findings like that only. That means am I right, Sonika?
Yes, sir. When I checked for cervical lymphadenopathy, sir, as a part of general physical examination, I noticed the swelling in the front of the neck, sir. So that's why I added it here, sir.
Even if you have found that swelling, doctor, what I meant was finish your pallor icterus edema, then echo performance, it's all fine.
Yes, sir.
I will describe the neck swelling later. That is better.
Yes, sir. Even when we are describing other swellings, when you go to the distant areas later,
yes,
to finish the local examination. So I think they should come in a separate thing as a local examination separately.
Yes, sir. The swelling
I also agree.
described later.
I think all examiners will expect this is a part of the local examination. So better exclude it.
Okay, sir.
Good, you have actually appreciated this when you were doing the general physical examination, but I think it should go as local examination.
Sure, sir. Yes, sir. So with this newfound point, sir, I would like to add some retrospective history that points to this, sir. I asked regarding the history of cough, breathlessness, and hemoptysis, sir, which is not there. There was no history of dysphagia or hoarseness of voice, sir. And there is no history suggestive of hypo or hyperthyroidism, nor there was history of loss of weight or loss of appetite, sir. So this is the clinical picture of the scalp swelling, sir.
I have some objection for that. What do you mean by retrospective history? I know what exactly you mean by that.
Yes, sir.
What is the duration of this swelling?
So 6 months.
6 months.
6 months.
Do you think it's rapid growth or slow growth?
Rapid growth, sir. Rapid growth.
So what is the first thing you have in mind? Metastasis.
Metastasis. Secondary. Yes, sir.
So then what is the thing which you would like to ask at this stage itself? Since we know that I know we don't know what is the site of origin at this stage, but at least you can finish there only. Apart from this, patient does not complain of any other complaints. Over. Finished. That solves your problem.
Yes, sir.
See, I think Sonika, though you are trying to maintain the suspense, it is probably not required. I think you should, having gone back and taken the history, you can present it.
Yes.
So I think that is perfectly acceptable because patients do not know what they are saying. So it is up to you to actually identify what is the problem and then go back and ask certain relevant history and present it in the history. Not a problem.
Yes, sir.
Okay.
Yes.
Carry on.
Yes. Next slide. Local examination of the scalp swelling. On inspection, a solitary swelling of size 18 to 6 centimeters is noted in the left frontoparietal region with well-defined borders, smooth surface, and skin over the swelling appears normal. No scars, no sinuses or dilated veins, and no visible pulsations. Coming to the palpation, there's no local rise of temperature. The swelling is non-tender. A well-defined globular swelling of size 18 to 6 centimeters is noted in the left frontoparietal region. Again, well-defined borders, smooth surface, and skin is pinchable. And there is no, there's restricted mobility. The swelling is soft in consistency. The swelling is pulsatile. Underlying bony defect is palpated anteriorly. No impulse and cuffing, and no palpable regional lymph nodes.
Sir, Dr. Shenoy, sir, do you expect the swelling of this size and its location for it to be mobile swelling, or would you expect it to be fixed?
No. Mobility is what it will take away the main diagnosis itself.
See, when it is arising from the obviously a bone only destruction there. It cannot have a movement, but what she meant probably, I think only a tip may be moving a little bit. I think so.
No, she said restricted mobility. That is why I asked that question.
So better not mention that.
Correct. That is what I wanted to bring that point.
Yes.
When there is a hard bony swelling, you can't expect it to be mobile at all.
And remember, swelling, when you elicit mobility, is at the base of the swelling. You hold
Correct.
the lower
Correct.
part of the swelling and try to move it. The upper part may move a little bit. Kindly do not do that. Elicitation of mobility is from the base of the swelling in relation to the deeper structure.
Correct.
Yes, sir. Yes, sir.
I think you are confused for the mobility of the scalp layers over the top of the swelling than the swelling itself. I don't think the swelling should be mobile at all.
Right.
Yes.
And
yes.
Okay. So you got that point, Sonika?
Yes, sir.
Continue.
Yes, sir.
Continue.
Yes, sir. Next slide.
What I want to also add there, just show the clinical signs, otherwise we'll forget.
Yeah, correct.
Go to the
One more point.
palpation finding. Yeah, just
Yes,
that.
Palpation.
So there are one or two things here. Do you expect a local rise of temperature in this patient or not?
Yes, sir. It could be there, sir.
So it is
Because of
possible.
vascularity.
Just look carefully. So soft in consistency should be immediately followed by fluctuation. Should be. I'm not seeing that here. So you need to mention fluctuation is present or not. You understand?
Yes, sir.
So because you are written there, well, that means enough bone is destroyed. Enough bone can be destroyed there. So there could be a vascular tumor. May fluctuate, may not fluctuate. That is a different issue. Okay.
Prajwal, I have an important point to make here is she has told about well-defined borders, but she has to, I am particular to, she should mention what is this border. Because if it is, can you tell me what is the borders are like?
Sir, borders, it is anteriorly, sir, there's a dip, sir. There's a dip
That is the bone.
noted.
Yeah. Yes.
Yes, sir. And posteriorly, I could again make out the hard junction, sir. Again, this bone itself, sir, between the swelling as well as the rest.
No. I am telling you, you are talking about the consistency at different levels. That is okay. I am talking about the type of the margins. So whether it is sloping and merging with the borders, rest of the bone there, or is there a undermining and a groove you can feel?
Yes,
you know,
sir.
there is going to be a difference between the two.
Yes, sir. Sir,
I'll tell you why.
anteriorly, there was a groove, sir.
No, I will tell you why. If you are able to find a groove all around, if it is a swelling arising from a soft tissue, which has got later on fixed to the bone, that is how you can differentiate between that and a swelling which is arising from the bone itself. If the swelling is arising from the bone, you will have a sloping margin.
Yes, sir.
You can understand the epicenter of the tumor which is growing. You understand what I'm saying?
Yes, sir.
So naturally, the borders will not be rounded. So it will be sloping. So that is what is being described.
Yes, sir.
Okay, continue, ma.
Yes.
Continue.
Next slide, sir. So the swelling on percussion, it was dull to percuss, and on auscultation, bruit was heard.
What is the nature of that bruit? What do you mean by bruit?
Sir, it was present throughout the this one, sir. Actually, I could hear it more during the systole, also with every heartbeat, like when corresponded with the pulse. And yes, sir, it was more obvious during the systolic period, sir.
Okay, yeah.
So what is the significance of this bruit?
Sir, it tells about the vascularity of the tumor. So it is hypervascular, so well vascularized tumor.
Yeah, just that you, with an arterial component being predominant, you get a systolic accentuation. Otherwise, you get a continuous venous hum, they say, that goes as a sound right through the entire phase of 2 beats.
Yes.
Thank you. Next.
Okay, continue.
Probably goes more in favor of AV malformations. When the arteriovenous visualize, the continuously heaving movements will be there. AV malformation.
Yeah.
If it is highly vascular, as it has said, it is a correspond to the systolic beat of a heart.
And she mentioned cough impulse here.
Yes, sir.
Arun, any questions?
Yeah, can she mention cough impulse? On palpation, she said cough impulse.
I would say yes, she can mention it, because that is communicating with the cavity that has connection to increased cranial pressure on coughing, and will indicate a deeper communication. That's all.
Definitely.
It's not expansile coughing spell. But it's just,
when we presented, there is a bony defect. I think she need to mention about this cough.
To be on the
bony defect she has mentioned.
To be on the safer side, yes, definitely intracranial communication. Yes.
Dr. Rajan was mentioning about mobility from the base of the swelling and not from the upper portion of the swelling. So If you feel it is mobile, then what is that called, ma?
Top mobility, sir. Only the top part.
Okay.
And, yeah.
Yeah.
Classically, we use that term not in this kind of large cystadenoma pancreas, no, some of the coming from the pancreas. So base of the pancreas will not move because this large swelling on the top may move like that.
Yes, sir.
So
Yes, sir.
better not to use that terminology. Means this patient here don't get into controversy. It is not mobile. That is better.
Okay.
No, sir.
Right. What is your clinical diagnosis, Norma? What do you think?
Sir, before that, one more question. Can I ask what else you have examined, doctor, other than the thyroid in this patient? I don't know whether you have mentioned or not.
Yes, sir. I have examined the breast tissue as well, bilateral breast, sir.
So you need to
Yes,
mention that specifically.
Yes,
you
sir.
understand the overall swelling may be just.
Okay. I think quickly go through the thyroid exam.
Yes, sir.
Before we move on.
Okay. Yes, sir. Examination of the neck swelling. On inspection, a swelling of size 3 is noted in the right side of the neck. It has the surface and moves with deglutition up to thyroid cartilage, medially up to the midline, and inferiorly it is noted at the medial end of the clavicle, and laterally up to the sternocleidomastoid. The swellings in neck. So this is the there's a swelling noted to the right side. Sir. On palpation, a swelling of size 3 × 3 centimeters is palpated in the right side of the neck. It has well-defined borders. Here, inferior border is also well made out, and the surface is smooth. The left lobe of the gland is not palpable. The swelling is firm to hard in consistency, and the swelling moves with deglutition. There are no other palpable swellings in the neck. Trachea is central. Bilateral carotid pulsations are felt in the normal position, and no cervical lymphadenopathy noted.
Okay. So go to the rest of the examination, breast, and you said about what else would you examine in view of the what Dr. Shenoy had said before.
Examination of the breast, examination of the abdomen, basically the systemic examination.
Correct.
Sir. In this patient, sir, it was normal, sir. There was no organomegaly or no significant findings. Sir.
Okay, fine. So with this finding, what is your clinical impression?
Did you mention about the regional lymphadenopathy? I know you have mentioned generalized lymphadenopathy.
No, yes, she did. She did. She did.
She mentioned no other swellings in the neck. She mentioned no other swellings in the neck.
No. That I wouldn't.
No, she did say specifically. She did say no cervical lymphadenopathy.
At the peak,
postgraduates, I think we expect when there is metastasis there in the scalp. You should mention about the no cervical lymphadenopathy.
She did. She did. I think she did.
He did mention.
I will come
in here. You are told about spine is normal, is correct. You should look for other bony swellings. What are the other sites where you can expect bony swellings in this case?
Sir, in the chest wall, sir, over the ribs, then in the lower limb, sir, especially femur, and also spine, sir, flat bones are.
Flat bones, but not femur.
Yes,
I think pelvis,
flat bones. Yes,
hip and spine. I think that's more.
Yeah, you should remember that thyroid always follicular, mostly for flat bones.
Flat bones.
And the breast, especially breast malignancy, tenderness. You look, vertebrae, and femur, etc. Okay.
Sonika, one more. Siddheshwar was particular about the lymph node. That is mandatory. Whenever thyroid swelling is there, you need to look for the lymph nodes. Retrospectively, looking at this diagnosis, do you expect that lymph nodes to be palpable in your case?
Sir, it could be palpable, sir. Even though follicular malignancy, they're more prone to have hematogenous spread, so they could have lymphatic spread as well. Sir.
Yeah. I could expect it. It can be possible. It is uncommon compared to the hematogenous spread. Since we are thinking in terms of follicular carcinoma, incidence of lymph node metastasis is very less. Do you know what is the incidence of lymph node metastasis in follicular carcinoma?
I'm not sure, sir. Around 10 to 20%. Sir.
hardly around 10 to 20%. Remaining around 80%
yeah.
is an hematogenous.
Yes.
Till then, examination of the lymph nodes is a mandatory when you are examining the thyroid swelling.
Yes, sir.
Okay, so what is your clinical diagnosis?
Sir, I would like to label this case as a case of secondaries in the scalp, sir, with primary in the thyroid, sir. So, in other words, CA thyroid with bone metastasis.
Can I put the TNM staging for this?
Sir, T2, sir, N0, M1, sir.
Which classification it is?
So this is AJCC 8th edition classification, sir.
Okay, fine.
Sir, so
the common questions they will ask you is why not that is scalp swelling is a it may look simple, but people have incised thinking that it's a lipoma and get into problems. Why not it's a lipoma? Do you answer this question quickly?
Yes, sir. Sir, clinically, sir, there is the swelling is pulsatile and there is a bony defect which is palpable, sir. So with classically there is no slip sensor. It's a kind of it's soft in consistency, not very much like lipoma, sir.
So rapid growth. See,
rapid growth. Yes, sir.
Key points. Elderly, rapid growth. And you mentioned about vascularity, very important point. Yes, no localized temperature. You showed me that even that vein was very much visible. You did mention, indicative of vascularity.
Yes.
So that's the end bony defect. Okay, so you have to keep it in mind that yes, correct.
So I think this case, I think a lot of clinical examination points were brought out. So, and previous case we did bring out the investigation. So I think it's already come to 6 o'clock. With the permission of the secretary, I think we should stop this case, or should we give 5 or 10 minutes for investigation?
Management. Sir, can you go ahead?
I think we should go ahead with the management a little more.
One or a few words. Only management. Forget about the investigation.
So,
we have to.
Shanai sir, please take lead.
Yeah. So how do you go ahead now quickly? 1, 2, 3, 4 investigation, so that next end management. Yes.
Yes. Yes, sir. So first, I would like to go with the imaging study, sir.
Yes.
I want to confirm the diagnosis, sir. So
yes.
I would like to order for a CT of the brain, sir. CT brain with neck, sir. And also because since it's an advanced disease with metastasis, sir, I would want to do the metastatic workup, sir, like ultrasound of the abdomen. And also.
So if you just do a CT brain and chest, it is over, is it? So you would like to do a whole body bone scan here, don't you think so?
Yes, sir. Yes, sir.
Only one metastasis. So you understand what I'm telling?
Yes, sir.
So no, it is not confirmed. You may see only one metastasis. So you have a metastasis in the scalp here. So you should mention now first is the ultrasound, Thyroid's grading, and
yes,
then
sir.
of course Bethesda, Bethesda. Here it's the obviously lesion is there.
Yes,
obvious lesion is there. So this is how you proceed with that. Yes.
Please
Next.
note, when you give a region for scanning studies, it is the region. It's not
Yes.
CT brain, but rather head and neck CT. Heads.
Okay, sir.
Yeah, it's abdomen CT, chest CT, lymph CT, not the organ. You mentioned the region, please.
Yeah.
Yeah.
So would you still do an FNAC before you do all the CT and things in this case?
FNAC of the swelling, no. It's such a vascular swelling.
Vascular swelling.
Try to do anything.
The neck maybe.
Neck, if you want, you can take it. Yes.
Ultrasound guided FNAC of the thyroid. Probably.
Thyroid nodule. Yes.
Yeah.
I think you have to prove it by FNAC. So thyroid nodule FNAC is necessary. And CT of the neck, because she has not mentioned mobility of the swelling in her palpation.
She said it moves in deglutition. She said the movement of the.
Yeah, but intrinsic mobility. Intrinsic mobility is also important, whether it is infiltrating trachea or esophagus. That is made out on a CT.
Okay, so CT of the head and neck will give us information regarding the swelling in the scalp. It will give us information regarding the thyroid and also neck nodes also, if there are any nodes that are present. Okay, and then FNAC of the thyroid function test. So this will give you information about the possible diagnosis and the possible, and we have to presume that the scalp one has metastasis from the thyroid as of now. And as Dr. Shanai said, bone seat, it's on bone scan.
Whole body bone scan.
Whole body bone scan to look for the.
So ultimately, FNAC is important to prove the diagnosis. It may turn out to be a medullary carcinoma thyroid, which can spread both by lymphatic as well as blood rarely. So
Correct.
whatever it is, treatment will go for a total thyroidectomy. That is how it is taken up.
may reveal
So
only
I think
a follicular neoplasm.
Yeah.
That is what
Yes,
most often
yes.
we can get.
Correct.
It can be medullary, or there can be a rare type of malignancy also anaplastic. But FNAC may give a clue, of course. But then you have to plan for a radioisotope scan. So which is avid to the follicular cells. So today, what is the molecule which is used? Is it still the radioiodine or
We use
something else?
technetium
Which is
99, sir.
Yes. So
Nowadays.
you should know, no more radioiodine scan is done. It is a technetium scan which is done even in for evaluation of follicular carcinoma.
Sir, there is a question in the chat box. If the swelling moves with deglutition, do we need to mention about intrinsic mobility?
So, the last movement which stops with malignancy is the movement with deglutition. That last movement of the swelling to be restrained in advanced malignancy.
Okay.
So you still have restriction of intrinsic mobility, which indicates that it could be involving the central structures of the neck and still move with deglutition.
Right.
This is little debatable. I asked various examiners across the country, do you need to do the intrinsic mobility of the thyroid? When even Makanlal Shah inquired, Dinesh Babu Sara inquired personally, so they expect the intrinsic mobility of the thyroid need not be examined because it is not the only thyroid moves. The whole component is moving horizontally. So you are not moving the thyroid alone. You are moving horizontally, you are moving the trachea, you are moving the esophagus. So all the structures are moving. The moment it is you show that you are sure that deglutition, clear cut.
Mobility of unilateral swelling.
But images are required. Definitely, I do agree. Images are required to look for the resectability and other things because there is involvement of the trachea, there is involvement of the strap muscles, probably. Invasive modality is required, but intrinsic mobility, there is different view about the different examiners across the country about ask. I want the opinion from Rajgopal.
Nothing, sir, but I will add only one point, nothing much, sir. Yes, solitary nodule which is hard and fixed, there comes a very important point of intrinsic mobility because only one, when rest, nothing is palpable because it may be an anaplastic carcinoma fixed to prevertebral fascia. That is the importance of the clinical inoperability. So that is why that is the time only checked. In a multinodular goiter, I never teach for intrinsic.
Exactly. This is a unilobar enlargement. This is not bilateral enlargement. So that is why I brought in the mobility. As I said, this is mentioned in the book that the last movement to stop with malignancy is the movement with deglutition. So there are other movements possible with thyroid, provided it is confined to one lobe of thyroid. Then it can be put apart from the trachea.
So
I think point is, I was wondering how Srivatsa is keeping quiet because he is the patient. I mean, a case of carcinoma thyroid. This valuable input was missing from him. Anyway, good that he has contributed. Very nice.
Okay, so I think good presentation, Sonika. I think it was very sleek. Keep up the good work. And I think we have covered a lot of clinical examination findings and how you should present these.
Ravi Shankar, sir, we have 19 more minutes. This is a long case.
Oh, okay. So
please continue, sir. Say till 6:30.
Okay, we can go ahead with the discussion of the management then.
Yes, sir. Please. Yeah. That's what I am requesting right from the beginning.
Okay, we can.
Half of it is.
I was under the impression half an hour for each.
No, there was a confusion. Because in the beginning it was told half an hour.
Yes,
this is a long case through, but actually it is a 45-minute case.
It is long case.
There are images, sir. We'll discuss about this.
Venkatesh, this is why you are our timekeeper and conscience keeper.
I think by an error, Dr. Venkatesh mentioned it is half an hour. So that's the reason why the confusion.
It's okay, sir.
Ravi, there are a lot of good images are there. You ask them to put up.
Yeah, Sonika, please put up the images.
Yes.
I just wanted to ask Dr. Shenoy, what bone scan are we looking at? Technician bone scan?
Sir, one more question. Now with this, this large vascular scalp swelling, thyroid swelling, what is there? Is there anybody in this panel who would like to think that they should get a PET CT?
I think instead of doing the whole body, this one that yes,
because that will it not influence your management because it's already secondaries. So would you like to do a PET CT?
Sir, we will come.
Ravi, one more. The majority of the thyroid swellings are not PET avid. Majority of them are not PET avid.
Correct. No,
Ravi,
no, I wanted to bring these points for the benefit of the students.
Venkat here.
Yeah, Venkat, come on.
FDG is not usually done because we know that it doesn't uptake FDG. If at all, if it is done by somebody by mistake and if FDG is taken up, it is a very bad tumor. It is a dedifferentiated tumor. So we may do a bone scan, we may do CT scan of the neck without IV contrast because iodine contrast can trouble later.
Yeah.
So we may do that.
Correct. See, this is the point I wanted to bring because people will always think that we should get a PET CT. So the indications for PET CT are very clear. So this is not one of the indications. So please, students, understand, don't ask for PET CT in the exams. If this examiner asks you, please tell them that PET is not, the thyroid tumors are not PET avid and hence it is not necessary. Okay, so that is the learning point. So the bone scan and head and neck CT are the investigations of choice.
Clearly mention a whole body bone cancer in this.
Correct. Whole body bone scan is very important. CT of the head and neck is very important. And then I think as Dr. I think we also had the thyroid scan. I think Dr. Siddesh wanted a thyroid scan, which is I think right.
Thyroid scans is generally not required because they are the functional. They are all functional scan. There's nothing abnormality in the function about this. This is an E-thyroid, most of the malignancy.
Yeah.
Generally, thyroid scans are not required for this sort of cases.
We'll straight away your OPD. This patient comes to you, start with the blood test, and since we have time, I think we'll ask her properly, sir, how she proceeds with the investigation, and then we can
management. Yeah.
Tell. Yeah.
And put up the investigations as and when.
First, we got the USG of the neck, sir.
Okay. Say ultrasonogram. Next Don't slide. Tell USG and all that in the examination. Yes, go ahead.
Ultrasonogram. Yes. Yeah.
Yes, sir. Ultrasound of the neck, right lobe of the thyroid appears enlarged of size 3.7 into 4.1 into 3.2 centimeters with a well-defined heterogenic mass of 3.7 into 3.8 to 3.5 centimeters noted within predominantly the solid hyperechoic wider than taller fashion, punctate echogenic foci. Margins of the mass show calcification. The mass is in flush with the carotid sheath, pushing it laterally. Few subcentimetric lymph nodes are noted in bilateral level 2 and level 3, maintaining the fatty hilum. Left lobe and isthmus appear normal. So the impression is well-defined heteroechoic vascular lesion arising from right lobe of the thyroid group 5.
Okay.
Good.
So what is your impression?
Yeah. Okay.
With this information, what are the next investigation you would want to ask?
Sir, this would show that it's a thyroid 5 is suggestive of a malignant lesion, sir. I would like to go ahead with the USG guided FNAC of the swelling, sir. And before that, sir,
we will have to have any images. Sonika,
yes, sir. CT, sir. Yes, I would like to go ahead with the CT head and neck first, sir. Then go for the interventional studies such as USG guided FNAC, sir.
What exactly is the idea of doing a CT scan in your patient? You tell me.
Sir, in this case, it is to look for the cervical lymph node, sir. In this case, sir, even though there is metastasis, we can still the primary.
No. I just want to know from you what is the role of CT in your case in this patient. Just tell that local issues you tell. That's all I wanted.
To know the loco-regional extent of the disease, sir.
Like what? Like what?
Yes, sir. About the tumor and its relation with the surrounding structures like the trachea, sir. If there's any fistulation between the trachea
not
and
fistula.
No.
Don't
See, don't get into trouble. That is why I ask you, everybody says CT of the chest, CT of the neck. What is that you are worried at surgery? Anyway, you have to do total thyroidectomy.
Dr. Srivatsa has very clearly told you what is the read for the CT scan.
What is the important advantage of the CT scan? You are doing a total thyroidectomy. What is the structures? You are worried. You have to be careful. That's all it is.
He specifically told you. And you, the ultrasound also mentioned carotid sheath.
Yes.
See, the ultrasound cannot actually say whether there is infiltration, but CT can. So that is why you want to know.
As I mentioned, push posteriorly. Ultrasound
Correct.
Push posteriorly.
Yeah. That is why you want to know whether there is any infiltration or not.
Yes.
Sir, why I ask this? Because very often they will tell fixed to sternomastoid, fixed to jugular vein, fixed to like that. So see, all that structures can be sacrificed. You are mainly importantly, you should not cut the carotid. We have seen people cutting the carotid by chance, removal of a malignant thyroids. So that is what I wanted the answer in specifically in this patient.
One more better answer would have been to stage the disease. One thing.
Yes,
so
yes.
Indication of CT to stress the disease.
Stage
and
the
then
disease.
Clinically, it is node as negative. The nodal assessment would have been better because we are going to plan for a neck dissection for this particular case. And then contiguous involvement of the soft structures, particularly more than important. There is the trachea and then carotid sheath. These are very important. There is a need for to do for the CT neck in this case. Generally, for all the thyroid diseases, we don't require for that.
ತುಂಬಾ grammar mistakes ಇದೆ. ನಾನು correction ಮಾಡಿ ಕಳಿಸಿದ್ದೀನಿ ನೋಡಿ.
Sonika,
yes, sir.
You said on the ultrasound there were lymph nodes.
Yes,
what are the sort of signs on the ultrasound which will make you think that it may be metastatic?
Sir, first is the shape of the lymph node and size of the lymph node. Sir, lymph node size more than 1 centimeter. The shape normally it will be kidney shaped, sir. Loss of the fatty hilum and rounded lymph nodes, sir. And if it is heteroechoic, sir, with irregular borders, all of these will suggest malignant lymph nodes.
One more thing you missed. You mentioned all of that. Vascularity.
Yes, sir. Vascularity. Okay, sir.
Vascularity.
You mentioned taller and microcalcification. Did you mention microcalcification, etc.?
Taller than broader. That is another sign.
Important thing. Microcalcification.
Microcalcification. Taller than broader. Increased vascularity. And
So,
the size 1 centimeter and above.
So after the ultrasound, let us say you have done a FNAC. Do you know the criteria? FNAC, in whose name or which name it goes? Criteria? Heard of that?
Bethesda classification, sir. That's what we use, sir.
I won't ask you all the details. What do you mean by Bethesda 3? You tell me, because otherwise it will take a little more time. Quickly.
Yes, Bethesda 3 is ATP of unknown significance, sir, usually. So in this case, we will have to repeat the the FNAC, so USG guided FNAC. Sir.
And still it comes as negative. You need to go for a lobectomy, irrespective whatever it is.
Yes.
Okay. Right. What next? Let us say it comes as follicular neoplasm.
Yes, sir. So
and
if
go
Sonika, will they say follicular carcinoma or follicular neoplasm?
So they say follicular neoplasm. So on FNAC, we cannot make out adenoma or carcinoma, sir. So that is why we would go ahead with, in this case, so we will go ahead with a total thyroidectomy, sir, and send the samples, sir. On table, if there is involvement of level 6 nodes, then we will go ahead with the central neck dissection as well, sir.
When you're talking about frozen section with a follicular adenoma diagnosis, if you go in or a follicular neoplasm diagnosis, when you send a frozen section, will you get a definite diagnosis of a carcinoma on the frozen section?
Sonika?
Yes, sir.
Will you get a definitive diagnosis?
Will you get a definite diagnosis on the frozen section?
What is the principle of frozen section? What do they do?
So the cells, sir, they are stunned. They are put in liquid nitrogen, sir. We will just see the nuclear features, sir, of the cell, whether it is suggestive of malignancy or not, sir.
See, as you said, clinically our FNAC cannot make out whether it's follicular carcinoma. So what are the features which suggest it's follicular carcinoma?
Sir, it is nuclear pleomorphism, sir.
No, not
Sir,
nuclear.
the capsular invasion, sir.
Capsular and vascular invasion.
Vascular invasion, yes.
Can they make that out on frozen section?
One more important, Ravi. The standard recommendation for the thyroid is that there is no positive yield on a frozen section.
Correct.
But capsular and vascular invasions cannot be made out even with a frozen section study.
Correct.
The standard recommendation is there. You go ahead with the minimum thyroid surgery, wait for the HPA report. Depending upon the report, we need to proceed further. So generally, we don't recommend. If we recommend, the yield is very less. Very less.
I think that is the purpose of Arun's question.
Cannot be made out even on a frozen section.
That is the purpose of Arun's question. That was the purpose of Arun's
trying to drive. No,
Ravi, can I put a word?
Not be able to give us the diagnosis.
Venkat, carry your input for this.
Yeah. See what happens in frozen section. A bit of the tissue is taken in a fresh tissue and is placed on liquid nitrogen. It freezes in few minutes. Then they take sections, stain it, and
cryostat.
See. So you cannot. It is called as cryostat. You cannot see the whole detailed report in 20 minutes or 30 minutes. So they may see capsular invasion, but vascular invasion is very difficult to identify on frozen section. Vascular invasion is the hallmark of invasive follicular carcinoma. If capsular invasion is present, minimally invasive follicular carcinomas or follicular neoplasms, they are of undetermined significance. You can wait and observe.
So what is the standard recommendation, sir? You expect to do the frozen section, you don't expect.
No, you should not do frozen section. I think
now you need a diagnosis, whether it is follicular variant of papillary carcinoma. Some diagnosis you need, right, to complete the total thyroidectomy. So if you are sending for frozen section, you are looking for some information, you will get that information. They may give it as follicular neoplasm or with capsular invasion. Nobody will write it as follicular carcinoma on frozen section.
Sir,
one more
Sir, shall we say in this patient with the scalp swelling? Scalp swelling, we'll straight away say total thyroidectomy.
You have to go with your clinical data and go do a total thyroidectomy.
Clinical radiological images
and do a total thyroidectomy. What is the examiner's feeling about neck dissection in this patient?
No, sir. Unless the nodes are enlarged, clinically palpable, etc., there's no indication.
Ravi, follicular carcinoma usually doesn't go to the lymph nodes. Even follicular variant of papillary also.
Correct.
So if
so
they are
no
clinically involved, you can, or during surgery, if you think they're suspicious, you can remove that.
So that is why
one more recommendation is if your image shows that there are lymph nodes. Image and
intraoperative findings.
Of carcinoma, the minimum central compartment dissection can be advocated in this case. Central compartment.
So that is and I wanted the examiners to come out with this answer because what the students are expected to know, which is why I asked that question. So the student should know that follicular carcinoma in only about 10%, maximum 15% of cases will metastasize to lymph nodes. If there are CT findings, ultrasound findings suggestive of lymph nodes, if there are nodes positive on when you are dissecting, only then you do a central compartment nodal dissection. Otherwise, there is no indication to doing a neck dissection in follicular carcinoma.
Yeah. Even in papillary nowadays, there is no routine central neck dissection, sir.
Correct, sir. Unless they are clinically involved, not just central, even the lateral neck nodes also we just check.
Yes.
If they are involved,
clinically and if not clinically, even the radiological involvement is there. Probably then there is a role of frozen section for the lymph nodes. If it comes as a positive, you go ahead with the central compartment or a lateral neck dissection. If at all there is a role of frozen section, it is in the lymph node, not in the primary tumor.
Yeah. Srivatsa sir, your thoughts?
No. I was just looking at.
Srivatsa sir, just you can summarize and end the thing, sir. We can go for the third case.
Yeah. No, I'm just trying to say lymph node dissection indication would be Hurthle cell variant of follicular carcinoma. If you have a Hurthle cell carcinoma, there is increased chances of lymph node metastasis, provided it is found on operative exploration or on imaging.
Yeah.
Or if it is a medullary carcinoma, you need to do a prophylactic. If no metastasis, or with or without metastasis in the scalp.
So I will, thank you, sir. I will ask Dr. Ishwar Husmani to sum up how would he would expect the students to present this case and the prognosis of this lady.
Yeah, Ravi, this patient is not aware about the thyroid swelling. She came to us with only scalp swelling. So that's why we all the time we concentrate only on scalp swelling. The history has been taken pertinent to that, and examination has been pertinent to that. Then general physical examination, when we were looking for the lymph nodes, she found that there is a thyroid swelling. Then we went on to do the detailed examination of thyroid. That's what exactly she did. That's what we expect from our candidate also, because patient is not aware about that neck swelling. Neither she has a complaint pertaining to the neck. So I proceed her to expect as a present as a neck scalp swelling. Then during the examination, they found that there is a thyroid swelling. Then in detail of the thyroid swelling. That's what exactly happened in this case.
Yeah.
Then my area of interest in this case is they have to mention it as a carcinoma thyroid with the metastasis in the bony, the M1 disease. Then question is immediately asked which are other malignancies which produce the bony metastasis. Then other things. Then one more discussion we didn't bring it to the notice. What will be the manage for the scalp swelling?
Yeah.
What is it? How do we manage for that? We are all restricting our management only to the thyroid. What about the metastatic scalp swelling?
Sir, yes, sir.
Sonika, can you have any idea about that regarding the metastatic workup management?
Yes, sir. So if the metastatic lesion is resectable, sir, then we need to go ahead and resect the tumor and then subject the patient to radioactive iodine ablation, sir. Because then if we leave the metastatic lesion, even though if it's resectable, if we leave it there, the dose of iodine requirement will be higher, sir. So if resectable, we need to remove it and then put the patient on.
Stop for a minute and talk about in your patient with such a large lesion after total thyroidectomy, what will you do? Let answer my question. In your patient, you have done a total thyroidectomy. Now what will you do?
Sir, we could do the excision of the metastatectomy we could do, sir, and probably plan for a cranioplasty, sir, if possible.
Would you consider do any vascular intervention before you resect this scalp lesion?
Yes, sir.
What is that?
Sir, we need to do the arterial embolization. So we'll try to reduce the vascularity of the tumor first, sir.
So, sir, what answer I wanted was, sir, after total thyroidectomy, as usual, after the 4 weeks or so, it need to be ablated. So, suppression completely. After that, it reduces vascularity. Still, it persists. Again, as you mentioned, embolization and whatever it is. Last resort, when it is a single metastasis, with the help of obviously neurosurgery, etc., craniectomy, and this is it. Should not mention it in the first phase.
Can we go to the next case? Please continue the question and answers in the chat box. Please continue the discussion.
The single metastasis is important.
Yeah, I think Venkatesh, thank you.
Yes,
thank you.
Thank you, sir. Thank you.
Dr. Ishwar Husmani, what is the prognosis in one sentence for this lady?
This prognosis for 5 years survival is hardly around 10 to 20%. As well, so the literature says 5 years survival is around 20 to 30%.
Normally, thyroid swelling 5 years survival is between in the range of 90
very
to
good.
95.
Follicular carcinoma highly aggressive is already metastasis to the bone, and then there is slight intracranial extension also. The 5 years survival is hardly around 20 to 30%.
Correct. Okay. Thank you. I think it was an excellent presentation by Sonika. Congratulations. And good discussion about clinical features and also management. So we'll move on to the next patient.
This is also being the thyroid case. We can restrict this to 30 minutes, sir.
Okay.
6:30 to 7 o'clock. Yeah. Thank you, sir.
Right, Dr. Sriram.
Yes, sir.
So
Sir,
after you present the clinical, the history, stop, and then for the questions, and then clinical findings. Okay.
Okay, sir.
You just go with the brief information, don't go in detail, because now you'll have more time for discussion, I think.
Discussion, correct.
Probably only the positive history.
Yeah, okay, sir. Shall I go ahead?
Start.
Yes, sir. Good evening, everyone. This is Dr. Sriram from St. Martha's Hospital. So my case is going to be a 30-year male resident of Bangalore, software professional by occupation, present to our OPD with a chief complaint of swelling in the anterior aspect of neck since 4 years. Patient was apparently normal before 4 years, after which patient noticed swelling in the anterior aspect of neck, which was incidence in onset. When patient noticed the swelling, it was around 2 centimeters in size, and it gradually progressed to attain the current size, which is around 6 centimeters. The swelling is not associated with pain. It is associated with complaints of weight gain, lethargy, and fatigability. Patient has no history of hoarseness of voice, no complaints of difficulty in breathing, no complaints of difficulty in swallowing or dysphagia, and patient has no features of hyperthyroidism. Past history, patient has no medical history.
Yeah.
Yes, sir. No medical history. Patient gives a history of where he underwent a treatment for a similar complaint 3 years back, and he underwent a needle test procedure, after which they have given him information as a non-cancerous lesion, and post which patient has stopped taking treatment for the similar swelling. And personal history, mixed diet, normal sleep and appetite, normal bowel and bladder habits. And family history, there is no significant family history.
Okay.
Yeah. Just
What
wait.
Yeah.
Yes, sir.
So Venkat, what other information would you want in this patient?
Sriram.
Yes, sir.
Venkat.
Hello, can you go to the first slide? There were no symptoms other than the swelling, right? Nothing positive.
No positive.
Complaints of weight gain, lethargy, easy fatigability. You should ask for any family history, any other skin changes, constipation, and slowness in the activities, all those things. Voice change is not there. Any treatment, medication history?
No medication history, sir.
Medication history, drugs causing these symptoms.
Sir, just one or two comments from my side, sir.
Yes,
Yeah.
sir, please.
Go back to the first slide, Dr. Sriram. Please, that Bangalore should be B capital. Yeah, Bengaluru is okay, but B. Bangalore.
Yes, sir.
Small thing, you should not do such mistakes, it's in the open forum like that. Next, you show the next slide. Next slide. There are few more mistakes. Don't say swelling is associated with the complaints of weight gain, lethargy, not like that.
No.
What I expect is swelling is 2 centimeter, increase to 6 centimeter. Any rapid increase or sudden increase should come now. Okay. No history of rapid increase means malignancy or something. Sudden increase, hemorrhage. Then you can tell the patient does not complain of any weight gain. So toxicosis you would like to mention, or hypothyroidism. See, it should come later. See, pain should go up, hoarseness should go up, breathing, dysphagia, etc. Then comes hyperthyroidism, hypothyroidism, and features of malignancy. So that if you follow one order, you will not miss. I hope it's clear. That's all.
Okay.
Yeah. Dr. Rajan, any question?
Nothing. No.
Okay. So sum up the history, Sriram, and then go to the clinical examination.
Sir, history is a 30-year male with swelling in the anterior aspect of neck since 4 years, sir, which is a gradually progressed swelling. And the patient also has history of weight gain, lethargy, and easy fatigability, sir.
Okay.
Past history treatment of needle test showing a non-cancerous lesion. General examination, shall I go ahead?
Yeah.
Yeah. Go ahead. Go ahead.
Yes, sir. Patient is conscious, oriented, and cooperative, sir. And patient is obese, has BMF 33 kg per centimeter square, sir. And on vitals, blood pressure was examined in the right brachial artery, which is around 110/70 millimeter of mercury, and pulse rate is around 78 beats per minute, sir. And his ECOG score is 0. There is no pallor, ictus, or clubbing, or synesthesis, or lymphadenopathy, or edema noted, sir. Examination. Next, shall I go ahead?
No.
Here, you mentioned the no features of hyperthyroidism. Again, there is no need to mention about the eye signs here. When you said no features, both symptoms and signs are covered. So probably no need to mention about the eye signs here.
So you mentioned about lethargy, weight gain, and all that. So in view of that, are there specific findings that you would like to examine in this patient, Sriram?
Sir, skin features are cold climate skin, sir.
Correct.
Eyebrows.
Tongue.
Yes, sir.
Always start from the head and go down to the foot. You will not miss things.
So what happens to the tongue? What happens to the skin?
Madarosis.
Madarosis in the eyebrows, sir. Look for eyebrows, madarosis. Then tremors in the tongue, sir.
Not tremors, man.
That is in toxicosis, man. In hypothyroid, what do you get?
You're talking of hypothyroidism. So why are you talking about tremors?
What happens to the tongue?
Sorry, sir, I don't know. Dehydration, sir? I don't know.
No, thickening of the tongue, no?
Yeah.
Sriram, one
Yes,
or two things you should know. As you start talking, you said some needle test. Needle test is, you can straight away tell, sir, 5 needle aspiration cytology is done. You understand?
Okay,
For
sir.
thyroid,
Yes,
nobody
sir.
will do true cut examination. So let us be, we are postgraduates. That is
Yes,
number
sir.
one. Having done the test, doctors told no treatment is required and patient has lethargy means, what do you suspect now? Tell me. Hyperthyroidism or hypothyroidism?
Hypothyroidism.
So then that is what is the sir is asking you, correct? So do you expect
sir.
tongue tremors in your
No,
patient?
sir. No, sir.
See, everything in thyroid disease will be swollen in hypothyroidism, will be more in hyperthyroidism. Hyperactivity, hypoactivity. Everything will, metabolism will slow down.
Yes, sir.
Okay, so what other features will you see? As soon as you look at a patient with the hypothyroidism, what do you surmise?
Obesity, sir.
Obesity, and then
Weight gain, sir.
and how does the patient look to you? Yeah,
Response and attitude of the patients.
correct. What will happen?
Slow in the response, sir.
They will appear to be
Little slow or lethargic.
correct.
What about her voice? If you ask her her name and everything, what will be her voice?
Voice, what will happen to the voice?
Pitch of the sound will come down, sir.
That slight difference in the nomenclature, sir, somebody can clarify. Weight gain is different and obesity is different. You understand?
Yes, sir.
Sriram,
Yes, sir. Yes, sir.
your hypothyroid patient will become obese or they will gain weight?
Gain weight, sir.
Yeah, obesity may be a totally different thing.
Yes.
Yeah, I think the voice will be coarse, man. You know, they will have coarse voice, thickened tongue,
yeah,
and appear drowsy and lethargic.
Lethargic. They will not answer to your question properly. It will take a little time to understand. And then if you ask them to walk, the way they walk, the can be better. They're all the gross features of hypothyroidism. Probably if you not get into subclinical hypothyroidism, then at the gross hypothyroidism, definitely they will have.
And the skin will be coarse, and they may have features of will they have mixed edema? So there will be non-pitting edema of the lower limb.
Yes, sir.
Okay.
Okay. So you should finish all these things in the general physical examination, because they're all specific features. When you talk about hyperthyroidism, you should mention certain things. When you talk about hypothyroidism, you should mention certain things. Then go to the examination of the neck. Okay.
Yeah, okay, sir.
Proceed with the
Hello?
examination of the neck.
Yeah, okay, sir.
Continue the
Examination.
examination of the neck.
Yes, sir.
If you waste time, we will not have time for questions. Okay, carry on.
After appropriate informed consent from the patient in a well-lit room and adequate exposure, patient was examined. Neck of the patient was examined. On inspection, neck is slightly extended. A single swelling noted in the anterior aspect of the neck, which is vertically around 8 centimeter and transversely 6 centimeter, extending laterally up to the anterior border of sternocleidomastoid on the left side and immediately up to the midline. The lower border of the swelling extending up to the suprasternal notch in the clavicle, and superior border is extending up to the thyroid cartilage. The surface of the swelling appears to be normal, skin appears to be normal, surface appears to be smooth. The swelling moves with deglutition, and the trachea appears to be slightly deviated to the right side.
Okay.
Yes, and next we have a video.
Carry on.
Shall I carry on with the palpation, sir?
Yeah. Okay, carry on.
Yes, sir. On palpation, swelling is no warmth and tenderness noted over the swelling. And swelling, inspectory findings are confirmed with the palpation, where swelling is seen in the left side anterior aspect of the neck, which is about 8 centimeter vertically and 6 centimeter transversely. The swelling extends up to the sternocleidomastoid on the left side anterior border sternocleidomastoid, and immediately up to the midline. The lower border is up to the suprasternal notch and clavicle, and the superior border is up to the thyroid cartilage. Skin of the swelling appears normal, feels normal. Surface of the swelling is nodular. Margins are well defined. The swelling is firm in consistency. Trachea is deviated to the right side. There is carotid pulses palpable at the normal position and no other palpable cervical lymph nodes. On auscultation, no bruit heard, and systemic examination. Cardiovascular system, both S1, S2 sounds heard, no other murmurs or no other murmurs heard, and respiratory system examination, bilateral normal respiratory burst sounds heard. Abdomen is soft, no that palpable organomegaly or tenderness. Regarding central nervous system examination, there is no focal neurological deficit or no other cranial nerves involvement noted.
Sriram, I have to ask you one question now before I forget. That
What cranial nerve involvement
sir,
would you notice with the swelling like this?
One minute, sir. I wanted him to answer one question. You have to check in the ankle. What is that sign in this patient? Especially if you suspect hypothyroidism or mixed edema. Yes. You know the answer or no?
No, sir. I don't.
See, in thyrotoxicosis, you have so much reflexes, sympathetic system is so much high. In mixed edema, there is a slow relaxation.
Delayed
Delayed.
relaxation.
It's called as one sign is described for the Woltman sign. WOLTMAN. Okay, is an American person. Woltman sign. Delayed relaxation of the tendon reflex. You look into the tendon of which tendon? Yes. Okay. Right. Okay. Please go ahead.
Patellar tendon, man.
No. Achilles, sir.
Achilles. It's ankle jerk. Delayed
that
ankle
is the specific thing that you need to mention.
Yeah, he has to mention, especially you suspect mixed edema. Okay. Yes.
Okay, sir. Shall I go with the analysis? So my provisional analysis will be a multinodal goiter with hypothyroid features clinically.
So I will ask you one question. He is no doubt only 30 years. See, multinodular goiter is a clinical diagnosis. Patient has hypothyroidism. So can you join these two and try to make one diagnosis probably? You understand what I'm telling?
Yes, sir. It's an colloid goiter.
Get your clue.
What is it likely to be?
See,
Sriram.
Yes, sir.
What is it likely to be due to?
Which type of thyroiditis or etc. can also have a nodular surface with
can you remember? Can you go to Japan? If you remember Japan, you may be
Hashimoto's thyroiditis, sir.
Good. At least you caught the clue.
Got the hint. Yes.
So what
normally, why I ask this, because whenever we ask complications of multinodular goiter, we never use the word hypo, is it not? It's hyperthyroidism, if at all. Secondary thyrotoxicosis.
Yes, sir.
So,
yes, sir.
And then other things are there, no? So, in other words, multinodularity is actually gland surface is nodular. Pathology is the one which you have to give a diagnosis. You understand what I'm telling? Functionally, hypothyroid, surface is nodular. So what is the combination diagnosis? That's what it is. What is I expect, right?
One more thing, when you made it as a hypothyroidism, so in the history you need to ask whether patient had a toxic feature prior to that. There is how the natural history of the Hashimoto's thyroiditis goes. Initially, there is short duration of pain, swelling, and then some of the symptoms might be there. Or biochemical variations will be on the higher side, and then as the natural disease progresses, it's fibrosis, and later gland also enlarged in size, and then later it go for fibrosis, and then it goes for hypothyroidism. There is usually natural history of the Hashimoto's thyroiditis.
Patient is a male that to 30 years. Very interesting thing.
So I am interested in something else in the diagnosis for this patient. It is a male patient. It is a large swelling. Maybe some hypothyroid features are there. What is your aim to examine this patient particularly? What are you interested? Sriram.
Yes, sir.
There is a young male patient is there. What you would like to exactly rule out in this case, rather than making it as a Hashimoto's thyroiditis as your diagnosis?
Malignancy, sir.
Yeah. So your aim and objective in this particular case, why you are thinking in terms of malignancy? Why you want to rule out?
One is the age presentation, sir. One is male.
Young male patient. Young male patient. So these two are the high risk factors for the carcinoma thyroid. Okay.
And malignancy can be hypo or euthyroid.
Yes, agreed.
Never hyper.
The general ratio to remember is 9:1. 9 times more common in males, the young males, for malignancy.
Yes.
So Sriram, if I ask you a question, do you have any evidence of malignancy from the time of history till the examination in your patient? Do you have any evidence?
Sir, evidence supporting me, chances of malignancy is one is age and the sex disposition. Clinically, size of the swellings.
What is the size?
Around clinically, I'm getting around 6 to 7 centimeters size swelling. 6 centimeters size swelling.
What is the size?
6 centimeters.
Even 30 centimeter size swelling, they can still be only multinodular goiter without malignancy. What I wanted is any histories there in the.
No, sir.
There is no rapid increase.
No other history, sir. No other history suggesting of
any risk factors.
Sir, no history of radiation, sir. No other history, sir.
So this is the time hypothyroidism is the most common complication of head and neck radiation given to other conditions. Sometime back, that last case, there was some mention about that, correct?
Yes, yes.
So whatever be the reason, nasopharyngeal carcinoma, head and neck malignancy, lymphoma, or whatever it is. So one thing is that. Second, clinically.
Again, Dr. Shanai, here is what mobility becomes interesting. Is there restricted movement in one side of the trachea?
Is it, yeah, Sriram, any evidence is there of that?
Regarding mobility, sir? Or malignancy?
In your case?
Mobility, sir is asking mobility.
In your patient?
There is no restricted mobility, sir. Swelling was.
Hardness, consistency?
Is firm and consistency, it's not hard.
Recurrent leg nerve paralysis? Not there.
So no history, no, sir. No history.
So lymph nodes palpable? No.
No, sir, no lymph nodes palpable.
So I think your diagnosis should be based on the findings and say, clinically there is no evidence. But when the discussion comes, when they ask you, you need, because it's hypothyroidism with this surface like this, sir, I would like to think in terms of that direction. Hypothyroid with nodular goiter. So that's what I feel. So
can he offer the differential diagnosis of malignancy? Can he?
With malignancy, sir?
No, I'm saying, I'm asking Dr. Rajgopal Chennai and the panel. Can he offer differential diagnosis?
Sir, in the clinical examination, probably in this patient, difficult to give, sir. Maybe second diagnosis. I don't know, sir.
So you agree with multinodular goiter?
With this surface, I will give my diagnosis is Hashimoto's thyroiditis is my diagnosis. Second possibility is malignancy, as you rightly put it.
But again, in this case, there is nothing features to suggest malignancy. So why should we give a differential diagnosis of a malignancy? I think you should just stick to whatever the multinodular goiter or the Hashimoto's thyroiditis, what is given. Because again, many examiners may not agree a benign and a malignant diagnosis of the same organ. There are no definite features. So they will tell you're jumping from one to another.
I think Dr. Arun is correct. It should be just
why we keep the possibility of malignancy in this case. Probably if there are symptoms are there, hoarseness, tiredness, and other things, then it's easy to put it as a malignancy.
Correct.
In the absence of these symptoms, if purely a swelling which moves with deglutition, thyroid is one malignancy. We need not wait for the hard inconsistency, fixity. A 2 centimeter swelling freely mobile can harbor a malignancy.
Yes.
Looking at the patient age and sex. So our area of interest in this particular case, we would like to rule out the possibility of malignancy because of the risk factors like age and the sex. If it has been a female patient, possibly I would not have brought it to the discussion of malignancy in this case at all.
The ruling out malignancy is one aspect, but then giving it as a differential diagnosis is another aspect.
I think we should, because
the investigation will be ruling out the malignancy.
Arun, I think we have to give
Dr. Srivatsa
diagnosis for the reasons that Ishwar Hasmani mentioned. And also it's a asymmetrical swelling one side of the neck, including that clinical feature. As Ishwar Hasmani said, you can't wait for hardness, and there would be no hardness in many of the malignancies.
That is thyroid, sir.
Dr. Arun, just wanted to add one.
Dr. Rajan?
It is like earlier only, I mean, sorry to say earlier means my teachers and all that. You can't give a benign and malignant, sir. It is not, I think, not much valid, sir, because right if a mass comes, we have always give a query sometimes of both carcinoma cecum and ileocecal tuberculosis. So there are many such examples. So I think
sir, I agree with you. But the thing is, some examiners don't agree to that. That was what I was mentioning. And second thing is, when we are evaluating, we will definitely get to know whether it is a malignancy or not. So it's not that we want to rule out malignancy, but whether he has to give it as a differential diagnosis here. That is what
keep
we
the
are
possibility of that.
The other way, my point is, we have seen malignancies in the most unsuspected thyroids.
Thyroid swelling.
So that being the case, I think even the literature suggests today we are boiling down to doing surgery only for malignancies and those suspected malignancies, unless otherwise the patient is having symptoms of pressure effects or anything else. So I think benign swellings, non-neoplastic, we are not supposed to operate unless there are pressure symptoms. So that is the tendency which is going to conservatism of thyroid surgery. Today we need to do surgery aiming to rule out malignancy. So that being the case, I think clinically, when you are not able to rule out malignancy, that is one of the indications for surgery.
Sir, I think we're adding confusion to the poor student. This is a multinodular goiter predominantly involving the left side with a differential diagnosis of Hashimoto's and a remote possibility of malignancy.
Done, sir. Done.
That's all. That's all.
Done.
Correct.
Okay.
Yeah. Please proceed.
Yeah. I think, I agree with Dr. Rajan. You know, I think the examiner should get the information that you are predominantly thinking about a benign condition, but you would not be averse to considering a remote possibility of malignancy.
Correct, correct. That's enough. That's enough. Let's not break it up more for them. Yeah. Correct. Because there is hypothyroidism, Hashimoto's is higher in the cards. That's why. Yeah, continue.
Right.
Sriram,
Sriram, how would you investigate this patient?
Sir, I would like to get a
5 minutes.
Yeah, put up some reports.
Briefly, relevant investigations. Forget about the routine.
How would you investigate this patient?
So ultrasound of the neck and like to get the
put the picture. Put the picture in the report.
No, sir, I didn't get the picture.
Put the picture in the report of ultrasound.
So I didn't get the reports. The report is not there with me.
None of the investigations are available, sir.
If any reports FNAC or it has been operated, or let us know.
Sir, sir, just give you a report, ultrasound report. You can read it out orally, sir. Just not put in the slide.
Read it.
Yes, sir. The thyroid function tests were normal in this patient, and FNAC.
So there is no hypothyroidism. There is no hypothyroidism.
Biochemical has not showed any hypothyroid features, sir.
Yes.
There is no hypothyroidism.
No, sir. Biochemical wise, there is no hypothyroidism.
Okay, fine then.
Weight gain is because of work from home, I say, sitting at home.
That is why I asked him very clearly about ankle reflux. That is why we were from the beginning, we are debating at 30 years hypothyroid and needle test and all that thing. So they have to be very carefully give the clinical examination, because this is online clinics. We have no way to examine the patient. Yes, go ahead. Please go ahead.
The ultrasound report is in thyroid swelling in the left lobe with mixed echogenicity and 4 into 4.6 centimeters they have given, sir. And left carotid artery is displaced posteriorly, and trachea is deviated to the right side there. Ultrasound.
Right side, right lobe?
Right lobe is normal, sir. Right lobe is normal, isthmus is normal. No, the lymph nodes are not seen.
Okay.
Somebody has done FNAC old report. What is that report?
FNAC report is colloid, sir. Colloid.
Yeah.
Now you've got a unilateral swelling, which is now you said euthyroid status biochemically, large in size, male patient. What would you like to do?
So I would like to, after the investigations, I would like to go ahead with left hemithyroidectomy of the patient.
So you'd like to operate, you'd like to offer surgery.
Yes, sir.
And how will you convince the patient for surgery?
What is the indication? Can you give me 1 or 2 lines? What is the indication of surgery in this particular patient?
Sir, it's an long-standing colloid goiter, sir. So
Okay.
Chances of malignancy conversions to be noted, sir. And
one, I think,
and another factor is an young male aggressive tumor can be.
Yeah, so you can take the history, young male patient with a long-standing goiter enlarging inside. So I would like to rule out the possibility of malignancy. Minimum surgery in the form of hemithyroidectomy I am doing.
What percentage chances?
Answer.
What percentage chances that it can turn malignant, and what cancer can arise?
So 10 to 15% chances of conversion to follicular neoplasms.
First of all, you should do a scan to see, thyroid scan, whether it's a cold nodule, hot nodule, or knowingly that it is hypothyroid, you will know whether it's a cold nodule. Cold nodule has 16%. Okay, warm nodules have 9%, and hot nodules have 4% chances of malignancy.
So there is very high chances to, according to this, there is very high chances because being a cold nodule is hypothyroidism.
The carcinoma which can arise is a follicular carcinoma in a nodular goiter, and in Hashimoto's it can be lymphoma.
Yes, sir.
And
exactly.
It's a 4 centimeter size, sir. It's a definite indication also for surgery in this patient, male patient, 4 centimeter nodule. So only thing is he was all the time harping on hypothyroidism. That's what the discussion went on.
Yes, sir.
Can we conclude and go to the next case, sir? The last
my only objection is, can he mention hemithyroidectomy as the treatment? Because we all know that currently the surgery indicated is total thyroidectomy, or you can say Dunhill's modification of total thyroidectomy or subtotal thyroidectomy. One side you remove the entire lobe, the other side you remove subtotal.
Yes.
Sir, in this patient, I don't know. I understood the finding as other lobe is completely normal.
Yeah, but ultrasound is not, always confirmatory. It is the histopathology, because I have done this and I've got a recurrence. I have done it in a woman with vascularity, one side lobe, removed one side lobe because vascular. I wanted to wait for a biopsy report of follicular carcinoma. Then it was a benign thing and it recurred after 2 years. There are multiple such instances.
I want you to know, tell the students what is the message they have to tell in the exam.
Yeah, sure.
For a patient like this, euthyroid,
call you later.
One side nodule, otherwise benign, what is the operation they are supposed to tell?
With the diagnosis of a colloid in mind with the opposite lobe normal, young patient, in this setup, my choice will definitely go for hemithyroidectomy. I consider this as a low risk in view of all the findings with the CT assessment, FNAC, everything, because I will not explore the other side, so that chances of injury, in case if it happens, recurrence, it will be on the other lobe. There will not be any issues like that, because total thyroidectomy, everybody should know that is a high risk of both recurrent glandular and parathyroid injuries. So I'm only talking about this patient. I'm not talking about with the finding of colloid with this finding. That's all.
With adequate counseling of the patient and probably a written information too.
But total, those who claim total also can be done. They're not the.
Yeah, it is not totally wrong away from our discussion. There can be still possibility of total thyroidectomy, but in view of a young male patient, rather than pushing him to hypothyroidism, they require the larger doses post-operatively. We can risk it because our need is to get the biopsy, tissue biopsy in this case, in the form of hemithyroidectomy. Let us do only hemithyroidectomy, wait for the report. Depending upon if it comes as a benign, treatment is over. Unfortunately, if it comes as a carcinoma, then you have to go ahead with the regional thyroidectomy. That's what I would like to say.
That is important. So
standard recommendation. You're looking at standard recommendation.
The point is the patient should be counseled on both options. If you take out the whole thyroid, you make him dependent on thyroxine at a much higher level. So you give the option to the patient also, saying that you can get away with one operation where we take away the whole gland out, or we can stage it and do hemithyroidectomy, and depending on the future, you may need a second operation. So that is the way it has to be discussed with the patient. Thank you.
Counseling is very important.
I think Prajwal can start with the last case of today, then we go to the thing.
Yeah.
Prajwal, you can start.
Yes.
Thank you, faculty.
Yeah. Good evening, everyone. Today I'm here to present a case on testicular swelling under the guidance of Dr. Ishwara Hasmani, Professor and Unity, and myself, Dr. Prajwal. Here is a 32 years old male patient with a daily wage worker hailing from Savnur, Haveri, came with a chief complaints of scrotal swelling since 1 year and left groin swelling since 2 months. Coming to the history of presenting illness, the patient was apparently all right 1 year back. Then he developed a swelling in the scrotum, initially on the left side, which is insidious in onset, gradually progressive to present size of about 15 cross 15 centimeters. There is no history of pain associated with the swelling. There is no history of variation in size with change in posture, coughing, and straining. And there is no history of ulcer or discharge over the swelling. There is no history of urinary complaints. And there is no history of trauma. And there is no history of breast lump. And there is no history of vomiting. The patient also gives the history of swelling in the left inguinal region since 2 months, which is initially of size approximately 4 into 4 centimeters, insidious in onset, gradually progressive to attain the current size of about approximately 6 cross 8 centimeters. There is no history of variation in the size, change with position, straining, and coughing, and there is no history of pain over the swelling, and there is no history of skin changes. And there is no history of pain abdomen, and there is no history of backache. There is no history of weight loss or anorexia, and there is no history of cough, breathlessness, or hemoptysis. And there is no history of mass per abdomen, neck swelling, or any other swelling in the body. And there is no history of lower limb swelling. And there is no history of seizures. There is no history of fever, and there is no history of drug intake. Coming to the past history, there is no history of any previous admissions or surgeries in the past. And there is no history of diabetes, hypertension, and tuberculosis. And the family history is not significant. And coming to the personal history, the patient consumes mixed diet, and the sleep is undisturbed, and the appetite is reduced, and the bowel and bladder habits is normal, and the patient is a chronic tobacco chewer since 5 years and is not alcoholic or smoker. To summarize my history, a 32 years old male patient who is a chronic tobacco chewer came with a chief complaint of swelling, scrotal swelling since 1 year and left inguinal swelling since 2 months. Thinking at the history level, I will probably think of testicular tumor with inguinal lymphadenopathy, and the other possibilities is hydrocele with left inguinal hernias.
Arun, anything in the history you want to ask about?
No, only comment I would like to mention is probably he was going on to like no history of. Probably if you can just put it together and make it a little more presentable.
Okay.
Correct.
Okay.
Can I ask one question, sir?
Yes, sir, Dr. Rajgopal, sir.
Just one left inguinal swelling and left scrotal swelling, correct?
Yes, sir.
Yes.
First diagnosis, testicular tumor, correct?
Yes, sir.
Testis drains to which level of lymph nodes?
Testis primarily drains to para-aortic lymph nodes, sir.
So what you have written there is inguinal lymphadenopathy. There is something which is a little bit.
Yes. If there is
actually, if I may come in here, this is a very gross misconception of inguinal involvement in testicular tumors. And this may put you on the back foot with the some of the examiners, because testis definitely drains intra-abdominally, para-aortic, and then goes upwards.
Yes.
So lymph node involvement in inguinal is only if there is scrotal wall involvement, then you can get a lymph node there. So I would be very cautious in putting a malignancy as a first diagnosis in this case. I think this should not be.
So just suppose I ask you the question, we'll ask him later about the testicular tumor and what is that inguinal lymph node, etc.
Yes.
So what I observe is it is there since 1 year, scrotal swelling 1 year, inguinal swelling 2 months.
Yes,
so why did he suspect testicular tumor?
Sir, it's a long-standing, sir, rapidly progressive in size.
1 year,
yes,
and you still suspect it to be a testicular tumor. What made you think of testicular tumor?
So the swelling is huge, sir, and it's a long-standing with rapidly progressive in size.
See, you are telling 1 year, now you are telling rapidly progressing size. We have not seen it criteria. Somehow some things are not matching. Srivatsa is also asking you the same question. Any other tumors we can suspect at this stage because of that? With the inguinal lymph nodes. If I believe that it's inguinal lymph nodes, if I believe it's inguinal, any other tumor can present both for testis as well as the inguinal nodes.
130 ಇದೆ ಇಂಜೆಕ್ಷನ್ಗಳಿದಾವ ಖಾಲಿ
So if the testis, if there is involvement of the scrotal,
ಅದು ಖಾಲಿ ಆದಂಗೆ ತಗೊಂಬಂದ್ವಿ ಬೆಳಗ್ಗೆ CT ಸ್ಕ್ಯಾನ್ ಮಾಡಿಸ್ಬೇಕಾಗತ್ತೆ.
There is some cross connection. Someone is not muted there.
Yeah. Hello?
Yes, sir.
Yeah.
Hello, sir.
See your the history findings and your, I think you asked for it when nobody usually expects you to give a differential diagnosis at the level of history.
Okay.
So, but you have done that. Now you are asking for trouble. So I would suggest that the students restrain from making a so differential diagnosis at the level of history.
Okay,
because
sir.
I don't think you are expected to do that.
Okay, sir.
Sir, even if they make, sir, they should know that testicular tumor with inguinal lymphadenopathy.
Correct.
It be extremely careful, as rightly mentioned, because he has no history suggestive of undescended testis which has been operated. Correct?
Yes, sir.
Yeah.
There is no history.
So if there is
the history has mentioned that no other surgery has gone in the past. No other history of any surgery in the groin he has mentioned in the history.
He has not answered your question.
Sir,
Pathology involving testis as well as inguinal lymph node.
Yeah, I wanted the answer from you.
Yeah. Do you know the answer or not?
Sir,
Prajwal, you got the question? What is the question?
yes, sir. I got the
Pathology
question.
will answer the question. You let him go ahead.
I think Dr. Shanai himself will answer the question.
I will ask him later, sir. We'll proceed.
Yeah. Okay, proceed.
Relevant.
Dr. Siddesh, anything in the history you want to ask, sir?
No. Let us go ahead.
Okay, clinical examination.
Sir, coming to the general physical examination, a 32-year-old male patient, moderately built and moderately nourished, oriented time, place, and person. There is no pallor and there is no icterus is absent and there is no pedal edema and there is a left inguinal lymph nodes present. Come to the vital parameters. The patient is AFib, right?
You skip this. It's normal. You can skip.
Yeah,
You can go to the local examination.
Coming to the local examination of inguinal scrotal region. Coming to the inspection of the scrotal region.
Change that fast, otherwise YouTube may block it. So please change it fast.
Okay.
Yeah, remove this, please. Quickly move to the next.
Yeah. The swelling of size 15 cross 15 centimeters in the left.
Move to the next one, please.
And now, okay.
Coming to the palpation.
Prajwal, you put all the photos and delete the photos and then you describe on your own. We are not supposed to keep the expense data for a long time on a screen.
Yeah.
Got it?
Okay. Okay,
Yeah.
sir. Got it.
Yeah.
Coming to the local examination inspection. So a swelling of size 15 cross 15 centimeters in the left scrotum crosses the midline raphe and superiorly extending up to the root of the scrotum, which the swelling is globular in shape, smooth surface, and the cough impulse is absent. The skin is tense and there is loss of rugae and there is no evidence of ulcer, discharge, or sinus or inflammatory sign. The right testis is not visualized on inspection. Coming to the inspection of the left inguinal swelling, a solitary swelling of size of about 16 to 5 centimeters present in the left inguinal region, extending up to the upper part of thigh, oval in shape with irregular surface. All borders are well moved and the cough impulse is absent and there is no pulsation seen. The inguinal swellings appear to be separate from the scrotal swelling. Coming to the palpation of the scrotal swelling, a swelling of size 15 into 15 into 10 centimeters present in the left scrotum crossing the midline raphe, superiorly extend up to the root of the scrotum, firm in consistency, smooth surface, and the swelling is non-tender and non-reducible and there is no local rise of temperature and the transformation test is negative and the heaviness of the swelling is felt. The skin is not pinchable in the left side of the scrotum and the get above the swelling is present. There is a loss of testicular sensation. A left epididymis is not palpable separately from the swelling and the left thickened spermatic cord is present. The right testis, epididymis, spermatic cord is normal with the testicular sensation present and the penis is normal. Coming to the palpation of the left inguinal swelling, there is a solitary swelling of size 8 into 6 centimeters in the left inguinal region, extending up to the upper part of thigh, oval in shape, firm in consistency, non-tender, irregular surface, well-defined borders. The mobility is present vertically across the inguinal ligament, and the swelling is non-reducible, non-pulsatile, and cuff impulse is absent. The left inguinal swelling is separate from the scrotal swelling. Coming to the percussion, the scrotal swelling and the inguinal swelling is dull on percussion. So next slide, please. Coming to the parabdominal examination, coming to the inspection, an ill-defined mass of size 15 cross 15 centimeters present in the left hypochondric, left lumbar, umbilical region, crossing the midline and does not move with the respiration. The swelling is smooth in surface, become less prominent on head or leg raising intestine, and the flanks are free. The next slide, sir. Coming to the palpation of the abdomen, a non-tender, well-defined mass of size 15 cross 15 centimeters in the left hypochondrium, left lumbar, umbilical, and epigastric region, crossing the midline about 4 centimeters from the midline. And the superior border is 3 centimeters below the costal margin, and the inferior border is 18 centimeters from the right costal margin. And the lateral border corresponds to the anterior axillary line. The mass doesn't move with the respiration, firm in consistency, smooth surface with bossulated surface in the left lumbar region. The finger could be insulated between the mass and the left costal margin. And there is no other mass palpable in the abdomen, no hepatosplenomegaly. Umbilicus is normal and renal angle is normal. Coming to the percussion, the mass is dull on percussion and surrounding area is resonant. The liver span is normal, there is no free fluid level, and there is no dullness in the renal angle. Coming to the auscultation, bowel sounds is present. Rectal examination, there is an internal hemorrhoids present at 3, 7, and 11 position, and there is no growth. Coming to the local examination of the neck, and there is no evidence of neck swelling or spinal tenderness. Coming to the systemic examination, respiratory system, there is normal work.
Go to the diagnosis.
Yeah.
To summarize my history, a 32 years old patient who is a chronic tobacco chewer came with the chief complaint of swelling in the scrotal swelling since 1 year and left inguinal swelling since 2 months. On examination, there is a testicular swelling with retroperitoneal mass per abdomen with left inguinal lymphadenopathies.
What is the significance of tobacco chewing? You kept on insisting on tobacco chewing.
Is there any correlation between the etiology? Could it be an etiological factor in your case? As Ravi asked.
Sir, it is not directly correlated with the testicular swelling, testicular malignancies.
So in that case, you should use your discretion, not mention it. Maybe a tobacco chewer.
Okay, sir.
If you had an oral malignancy, yes, then it becomes important.
Okay,
or CS stomach, it becomes important. Otherwise, not.
Did you examine for axillary lymph node specifically in this patient?
Actually, no, sir.
Why should you examine? Tell me.
That I think there is answer to his question.
Because from the beginning he is confusing us, so I am trying to confuse him. Yeah, quickly.
So to rule out any non-Hodgkin's lymphoma, sir.
So why suddenly said non-Hodgkin's? Why not you straight away say Hodgkin's?
So Hodgkin's lymphomas, to rule out lymphomas.
Very important. So you need to specifically mention in your patient, because even if there is a testicular tumor, large mediastinal nodes, lymph get blocked, and you can also get axillary node.
Okay.
You mentioned about supraclavicular.
Yes.
But the scrotal swelling is concerned. Okay, I will ask 1 or 2 questions. Why do you suspect malignancy as far as the scrotal swelling is concerned? Tell me.
What are the features?
There is a huge. Yes.
You have mentioned. Yes.
Tell. There is a huge swelling in the scrotal region, which since 1 year, sir.
Rapid growth. Okay.
Rapid growth.
Then is testis felt or not felt?
Examination.
And testicular sensation is absent, sir.
Is testis felt or not felt?
No, sir. Testis is not felt separately.
And how do you know testicular sensation? In a large hydrocele, you can't feel the testis. Very large one. You can't feel the testis. Okay. When you feel the testis only, the sensation issue will come.
Okay.
Correlate with other findings. Correlate with the other findings.
Students, please note this very important point Dr. Chennai made. If you cannot feel the testis, don't comment on the testicular sensation, please. Okay.
I would
Yes, Dr.
add a
Siddesh.
point here.
Yeah.
If the testis is part of the hydrocele, inside the hydrocele, it is not felt separately. Even a sickening sensation, which is comparable to the opposite side, should be taken as a testicular sensation.
He has to mention that sickening.
Yeah, he has to mention it. Unfortunately, he has mentioned on inspection the testis on the other side is not seen. I don't know, in palpation, did he mention about the opposite?
Yeah, in palpation it is felt.
He mentioned
But
the opposite side.
my point was here, how on inspection, even if the testis are not seen, can you say it is not an undescended testis on the right side?
I don't think you should commit on it. You just, after the examination, he has felt it. So this
No, that's okay, sir. It is just a question. The scrotum, hemiscrotum is well developed on the right side also. So unlikely to be an undescended. That's just a passing remark, not related to this particular case.
Okay.
So my question, clinical question would be, you told thickening of the cord. How is it relevant?
And adding on to the same question, thickening the cord is due to what?
What? In fact, that is
And
what I want.
What is
the
sign?
corollary?
What is the sign? What is that sign called?
What is that sign?
So the thickening of cord is due to cremastic hypertrophy. So
weight of the testis adding to the hypertrophy of the cremastic. But in addition, what Rajgopal is asking is, what did you? How did you examine the vas? How did the vas look like?
So
feel like. You should mention at the same breath.
Okay. Vas is normal, sir.
Vas is now. What is sign of vas? That's
Sign
what Dakshanay wanted.
Sir, to rule out there is any inflammatory lesion or
No. Yes.
To differentiate between the inflammatory lesion, in inflammatory lesion, the vas will be thickened or in beaded appearance. Sir. It's called a sign of vas.
In India,
tuberculosis.
Tuberculosis. So actually, the cord size may not be hypertrophied there, whereas the vas will be thickened. So that is a sign of vas. Whereas on the contrary, in malignancy, even the size is not very big. The weight of the testis goes up. So the cord hypertrophies, whereas the vas remains normal.
Normal. Okay.
So according to you, there is no transfiltration. So you think it's a testicular tumor with the secondary hydrocele, correct?
Yes.
Is that you mean to say?
No, sir. There is no hydrocele components.
That's what I was asking Dr. Rajgopal. The swelling itself is testis. So that's what he was
telling that.
The swelling is only testis. Yes.
But he
meant to say the whole thing is.
He mentioned transillumination. I was surprised when it is a solid.
Yeah, so that's why. That is why I asked that question, sir. I thought he is talking about secondary hydrocele.
No, he made a mistake. He shouldn't have mentioned transillumination.
Okay.
And I don't know why he also mentioned percussion as one of the examination for the inguinal as well as scrotum is percussed.
So the scrotal swelling is dull on percussion.
Arun, anything you want to add?
I just want to mention that when he was presenting the case and examination, he was going from inspection, the left testis, and then to the right testis, and then to the inguinal, and again palpation, right testis, left testis, and then going to and fro. So probably it would be more prudent if he finishes examination of the left testis, which is the pathological one, what is presenting, then go to the other areas, so that confuses the examiners. Inspection going through 3 different areas, palpation to 3 different areas. No, it's not probably the right way to do it.
Okay,
correct.
Correct.
I agree with you totally.
Now, why do you say it's a para-aortic lymphadenopathy? Just tell me quickly 2, 3, 4 points.
So there is no movement with respiration, sir, and the mass become less prominent on head leg rising tests.
Anything else more important? Location you have to tell always first. Location.
Yeah, it's located in the epigastric, umbilicus, and left hypochondric regions.
It does not move. No mobility at all.
No mobility.
Did you appreciate any pulsations over the mass?
No, sir. I could not appreciate it.
Okay. So, now, only confusing thing is what is that inguinal swelling going into the thigh? You are telling.
Sir, but the skin is not pinchable, sir. It might be involvement of the scrotal skin, sir. That might be metastasis to left inguinal lymphadenopathy.
Rajan, sir, anything to add?
It's just that there is a retrograde spread of tumor from the para-aortic lymph nodes to the inguinal on the left side. That is what has caused the enlargement on the left side, similar to lymph nodes. In this respect, he shot the lymph nodes on the right side. Inguinal lymph nodes on the right side could also get enlarged in retrograde spread.
Okay.
Inguinal lymph nodes can also get involved if there is involvement of the card structures. That means it spreads through the card structures.
Okay, sir.
Covering the card. That can lead to inguinal lymphatic spread. But in this patient, I don't know whether the card is normal or abnormal. He says it is normal, so I can't explain the inguinal lymphadenopathy.
No, sir. The left spermatic cord is thickening, sir.
Thickening is not involvement.
Okay.
Few words about management, sir. We have 6 or 7 minutes.
How will you investigate quickly? What
So
are the things?
only thing is hepatomegaly. Did you mention?
No, sir. There is no hepatomegaly. There is no hepatomegaly.
He mentioned it. He mentioned it.
He mentioned. Okay.
Yeah. Okay.
So
how will
if
you manage this patient?
With the routine investigation, sir, I will firstly do the ultrasonography of scrotum and the abdomen, and the tumor markers, chest X-ray, and CCT chest and abdomen, sir.
Which are the tumor markers? Mention them.
The alpha fetoprotein, sir, and beta HCGs.
Normal values of each, please.
Sir, alpha fetoprotein is 10 to 12 nanogram per milliliter, sir, normal range.
Any other things which is also important other than alpha fetoprotein and beta HCG?
Yes.
Sir, LDH, so serum LDH levels.
Very important.
Very
Okay.
important. Yes.
Because it is included in the staging.
Staging.
Yes. Okay. Please go ahead.
Apart from the routine investigations, I will do ultrasonography of the scrotum and abdomen, sir. So next slide, sir, please.
Some pictures are available, CT scan or something. Yeah.
Sir,
Yeah.
There is a raised beta HCG levels. Alpha fetoprotein is normal, sir, 11.2 nanogram per milliliter. But beta HCG is coming to the USC scrotum, a large heterogeneous mass with multiple foci of calcification noted, measuring 14 into 11 centimeters and shows increased vascularity. And left testis is not visualized separately, and right testis measuring 2 cross 2 centimeters. And there is a large inguinal mass lesion noted in the left side, measuring 5 into 4 centimeters. Coming to the USG abdomen, there is a large heterogeneous mass noted in the pre and para-aortic region, extending from celiac trunk with multiple calcific foci, suggestive of metastatic lymph node. And there is a floating aorta sign noted, measuring about 14 into 8 centimeters. And there is mild bilateral hydronephrosis. In chest X-ray, you can see multiple soft tissue densities noted in the right lung, suggestive of metastasis, cannonball metastasis. Coming to the
There's a mediastinal widening also.
Yes. Okay, sir.
Why do you think there were inguinal nodes then? You mentioned inguinal nodes, right? With the scrotal swelling, there were inguinal nodes?
Yes, sir. There is a swelling in the left inguinal region, sir.
Why do you get inguinal nodes in testicular malignancy?
Due to the retrograde spread from the para-aortic lymph nodes.
Not para-aortic. The first is the para-aortic get involved. They will spread retrograde to the common iliac nodes.
Okay, sir.
And then to the inguinal. I haven't seen. Maybe this is the first case.
Yes, sir.
If there is scrotal violation.
Yes.
If somebody operates through the scrotum,
okay, sir,
there can be inguinal lymph node involvement because it's a T4 disease. Then.
Yeah. We have discussed all these already.
There is one in the staging called as M1A, means it is a non-regional lymph nodal metastasis.
Correct.
Non-regional. So,
yes.
Okay, go to the CCT. We'll go for the investigations.
Coming to the CCT abdomen and chest, and there is a large, well-defined heterogeneous enhancing lesion measuring 12 into 13 into 15 centimeters.
Next slide, please.
Noted arrangement from the left testis. It shows multiple specks of calcification within, and it shows non-enhancing necrotic area within. The lesion is causing mass effect with shift of penile shaft to right, query neoplastic. The similar density lesion measuring 8 into 12 into 16 centimeters, noted in the retroperitoneal region with lobulated margin. The mass is encasing the abdominal aorta and its branches. It is causing compression of the left ureter, causing hydroeretonecrosis, and the mass is displacing bowel lobes laterally, firing metastatic lymph nodes. And there is multiple soft tissue densities measuring, largest measuring 4 into 4 centimeters noted in the right lung, cannonball metastasis.
So what is the final diagnosis?
Ravi sir, can one of the seniors sum up the management?
Okay. Venkat, would you like to summarize briefly the management of this patient?
Since this is a metastatic disease, first is we would like to do an inguinal orchidectomy because we like to know the histological type, and then the patient will go for chemotherapy, either 4 EP or 3 BEP, because you have to decide whether it is seminoma or non-seminomatous germ cell tumors. If it is seminoma, it responds very well to chemotherapy. You can still observe because there are extensive lymph nodes and lung metastasis. That is why chemotherapy will be the option. If it is non-seminomatous germ cell tumors, yes, chemotherapy will be considered. You have to follow up. If the disease responds very well to chemotherapy, you can observe them and follow them up. If it recurs later, they will go for second-line chemotherapy. If there is residual disease, say it is seminoma and there is residual nodal disease, you can consider for radiation to that area, to the nodal regions, provided the lung metastases have responded. If there is residual disease anywhere, whether it is non-seminomatous germ cell tumor or seminoma, of course, metastatic disease, or nodal disease in non-seminomatous germ cell tumors or metastatic disease, so you will consider for second-line chemotherapy. Whenever there is residual disease, other than regional area in seminoma, and any residual disease after first-line chemotherapy in non-seminomatous germ cell tumors, they will go for second-line chemotherapy.
Okay. So
nice summary. Thank you.
Role of do we need to look at the brain, because when there are so many metastases, is it prudent to look at the brain also, because
you should see if they are symptomatic. If they are symptomatic, you look for the brain, because CT scan will not evaluate the brain. You have to do for MRI. MRI scan must be done.
Okay. Right. So
cranial can be considered if there is brain involvement.
So just for the benefit of the postgraduates, the triple EP is etoposide
and cisplatinum.
Cisplatinum.
If you are using BEP, that is bleomycin, etoposide, and cisplatinum, chemotherapy is given for every 3 weekly for 3 cycles, 3 BEP.
Yeah.
Day 1 to day 5. Because bleomycin is given every week.
Okay.
Bleomycin is given every week throughout the 9-week course.
Venkat, in view of the extensive metastatic disease, what is the prognosis of this patient?
You can never underestimate these diseases. They respond very well like lymphoma. That is why in testicular malignancies, there are only 3 stages.
Yeah.
So they will respond very well. For those patients who don't respond, you will have to think of alternative options like second-line chemotherapy.
Lance Armstrong is a classical example. He had, the cyclist who won the Tour de France 7 times, unfortunately disqualified, but he had cerebral metastasis, bilateral cannonball metastasis, multiple retroperitoneal nodes, and he still recovered after full dose of chemotherapy, and he was able to compete 7 times in the Tour de France, which is the most grueling cycling race.
We have many long-term survivors, so it is
So the testicular tumors have got good prognosis despite extensive disease. So don't lose heart. Be aggressive. Okay, I think that is a message. So I think lot of clinical importance was brought out by Dr. Rajan, Dr. Rajgopal Shenoy, and Dr. Arun. So I think all students, please remember these things. So I think we will close this case here.
Yes, sir.
Just a last passing, as a passing remark, Matthew Wade, the Australian wicketkeeper, is also a cancer survivor, testicular cancer survivor.
Daryl
you, sir.
Cullinan, sir. Daryl Cullinan, South Africa.
Yes, Cullinan also.
Cullinan, yeah.
Thank you, sir. Can we go to the main thing of today? Dr. Nityanda Shetty endowment lecture by Dr. Ganesh Nayak.
Nice cases, sir. Thank you.
I think President will introduce him. Venkat, please.
So thank you to all the teachers for the excellent
Thank you.
clinical discussion.
Okay, can I take over, Harish?
Yeah, please.
Yes, Venkat. Yes, Venkat.
Please, sir. Dr. Ganesh Nayak, sir, with us. So just please proceed with the introductory note.
Good evening, Dr. Nayak, sir. How are you, sir?
Good evening, Venkat.
Welcome, sir. So to introduce Dr. Ganesh Nayak, most people in town know what he is. He has been a senior most cardiac thoracic surgeon in Bangalore. He doesn't need an introduction, but for the sake of formality, I would like to introduce him to the audience. He did his MBBS and MS from Kasturba Medical College, Manipal, where he worked as lecturer and assistant professor in the Department of CVTS between 1970 to 1973, during which time the first ever open heart surgery in Karnataka was performed. And he continued his further studies and training in USA at University of Columbia, South Carolina University, and University of Kansas, Memphis. So in 1980, he returned to India in Bangalore, and he worked as associate cardiothoracic surgeon, during which he worked for a project on juvenile mitral stenosis, which was funded and sponsored by Department of Science and Technology, Government of India. So he screened around 15,000 school-going children, particularly for rheumatic heart disease, and also treated many of them for their valvular problems. In 1984, he joined at Untitled Medical College Hospital, where he established as well as ran the department for a good number of time. So state, we know what difficulty has done this CVTS coronary bypass surgery in Bangalore with all those primitive setups that he had. So yes, he's also pioneered a number of vascular surgeries such as splenorenal shunt, abdominal thoracic aortic aneurysms, AV fistulas for chronic renal failure. So he has been recognized by many distinguished awards, particularly the Dr. B.C. Roy Award, the Doctor's Day B.C. Roy Award by IMA Bangalore. So he is presently consultant cardiothoracic surgeon and vascular surgeon at various hospitals in Bangalore. He is formerly managing director and vice chairman of Bangalore Institute of Oncology, or HCG, which is the largest cancer care network in the country. So we wish him all success and happiness, and we're extremely happy to honor Dr. Ganesh Nayak on this day for delivering the prestigious Dr. Nityanda Shetty Memorial Endowment Lecture. Dr. Ganesh Nayak, sir.
Thank you, Dr. Venkat. At the outset, let me thank President Venkatachala and the organizers of the Surgical Society for giving me an opportunity to render Dr. Nityanda Shetty Endowment Lecture. Briefly about Dr. Nityanda Shetty. Dr. Nityanda Shetty was a dynamic young surgeon and was an active member of the Surgical Society of Bangalore and was a reputed cardiothoracic surgeon. Born in 1952, completed his MS in general surgery in Davangere and MCH from CMC Vellore 1985. He returned to Bangalore and joined St. John's Medical College and later became the professor and head of the department in 1989. Later joined MS Ramaiah College as the head of the Department of Cardiothoracic Surgery. He was an excellent surgeon, very popular teacher, and above all, extremely good human being. He was recognized as a giant in the field of thoracic surgery and performed innumerable number of complicated surgeries. He was a good friend of mine, and there were several occasions he has helped me with the difficult thoracic cases. and I had in return assisted for him for a number of CABG cases when he requested for. Though we worked in different institutions, we developed very cordial relationship. In 1991, I resigned from Ramaiah Medical College Hospital as the chief cardiothoracic surgeon, and the post was offered to Dr. Nityanda Shetty. The first thing he did was he came to my house for advice and blessings. I was very happy that he joined, and he did extremely well, took up a good job till his demise a few years ago. The subject for the lecture is disease of the aorta. Today, I want to share with you my surgical experience and challenges in the management of two conditions: aortic occlusive disease and abdominal aortic aneurysm, popularly. The study includes 58 cases of aortic occlusive disease and 19 cases of abdominal aortic aneurysm. The number of cases in this study small because I have not included number of cases that were done in small nursing homes and outside Bangalore. Most of these cases done in 1980s and 1990s. During this period, there were no dedicated vascular surgeons at Bangalore. It was Dr. Nityanda Shetty and I shared the space of vascular surgery. And as for both of us, cardiac surgery and thoracic surgery were the major part of our practice, and vascular surgery was a kind of part-time. Aorta is a conduit through which blood ejected by the left ventricle is delivered to all systems and organs in the body. Extensive arterial network. In adults, the diameter is 3 centimeters at the root, becomes 2.5 centimeters in the thorax and 2 centimeters in the abdomen. It is not just an anatomic conduit, but it also contributes physiologically. The aorta is distended during the systole to receive large portion of the stroke volume, Because of the elasticity during the diastole, so that during the blood continues to flow to the periphery. Because of the continuous exposure to high pulsatile pressure, the stress of and also stress, the aorta is prone to diseases and also aneurysmal dilatation and sometimes a rupture of the aneurysm as well. Aortic occlusive disease, which used to be relatively rare in 1980s, has been steadily increasing in number in the last 2 decades. Chronic occlusive disease is produced by atherosclerotic changes in the wall of the aorta and may affect the part of the aorta, but more commonly seen in the distal part of the abdominal aorta. In this series of 58 cases, I have not included any thoracic aortic disease, and all 58 had infrarenal aortic occlusions. I have not included any thoracic aortic disease. Out of the 58 cases, 12 patients had disease limited to the distal part of the aorta, 24 distal part of the aorta as well as common iliac arteries, 10 had disease extending to the external iliac artery. 10 had disease extending and to the external iliac artery in the femoral and popliteal arteries. Clinical data. As you can see here, majority of the patients, the age group was 50 to 60, and there were 32 patients in this group. 10 were in the age group of 45 to 50, 8 between 60 to 70, and 8 between 70 to 79. 79 was the oldest patient. Clinically, symptoms are claudication pain. It may be mild or severe or even rest pain. Minimal symptoms were seen in 8 patients. The diagnosis is simple: absence of femoral and distal pulses. Ischemic toe on the foot is seen also in some people, and in some people, frank gangrene. Right. Investigations: duplex ultrasonography of the abdomen, peripheral vascular Doppler, CT angio, MR angio. Investigations and conventional iotography are available, but CT angio gives just about all the information required for planning proper surgery. Conventional iotography is done only in special cases, particularly in patients with coronary artery disease. The surgical procedure for this, standard procedure is laparotomy and bypass surgery using synthetic graft. The procedure, what is done is through a midline incision, laparotomy is performed. The small intestines using synthetic graft. The small intestines were pulled out of the field and put it in the bag, moist bag. This exposes the retroperitoneum, and the peritoneum covering the aorta is incised from the point of renal veins proximally, distally to the aortic bifurcation. Renal veins This procedure was done in 54 patients. Once you have a loop around the proximal part of the aorta, just below the renal vessels, and a loop around the distal part of the aorta, the procedure becomes simple. All you have to do is cross-clamp the aorta, make a small aortotomy below the renal vein, and anastomose Y graft, proximal part of the Y graft. The distal part of the Y graft is taken down either to the common iliac arteries, or if there are disease in the common iliac arteries, it can be taken down further up to the femoral artery in the groin. Laparotomy and endarterectomy. Laparotomy and endarterectomy was done in 2 patients. Now, this is a case where there was a localized blockage with a good distal aorta. The procedure is same, laparotomy blockage. The procedure is same, laparotomy loops around the proximal and distal part of the disease, aortotomy, and core out the disease part of it. In the 2 cases that we have done, we required to put a small patch graft, Dacron patch graft, and the other one was completed by primary closure of the aorta. Thromboembolectomy. Thromboembolectomy was done in 2 patients. Occasionally, it's not a very common condition. Occasionally, you have a patient with aortic block suddenly producing acute and chronic situation. Occasionally, you have a patient with aortic block where patient presents acute and chronic situation where patient.
Harish, please ask other to log out from your Wi-Fi connection. Multiple people have logged in. Harish, please ask. Only one can log in.
Log out properly. Clearly log out. Yes, sir.
The symptoms in these people are very dramatic patients come within, say, 8 hours to 24 hours. Both the limbs are cold, are very dramatic. Patients come within, say, 8 hours to 24 hours. Both the limbs are cold, no pulsations. This requires immediate emergency surgery. Surgery is basically simple by doing a groin incision, vertical groin incisions, do an arteriotomy on both sides of the femoral artery, and then using a Fogarty catheter, these clots were removed. And the results are also dramatic, they do extremely well. One of these two patients came back after 3 months and required iliofemoral bypass graft. Now, amputation of the toes, particularly patients with a gangrene or ischemic changes or loss of skin, some surgeons do it in the same sitting, but I generally wait for some more time for two reasons. The gangrene, which appears to be very big, may shrink in size. Secondly, these toes have got organisms, germs, organisms, bacteria, and if you do an amputation, my feeling is there may be bacteremia and you have a foreign body graft, and if you do an amputation, my feeling is there may be bacteremia and you have a foreign body graft, it can get infected. What are the risks and results? High risk is seen in elderly patients, in patients associated with the cardiac, pulmonary, and renal diseases, patients with diabetes, hypertension, smoking, and obesity. Majority of the patients have done well, and obesity. We had 4 deaths in this series, 2 have done well, 1980s, and 2 later. Out of the 4 deaths, one died on the 4th postoperative day due to MI. He was 76 years old. One died of pulmonary embolism on the 9th postoperative day, and 2 died of a poorly controlled diabetes, wound infection, septicemia. And both these cases were done in the early part of 1990s. Coming to abdominal aortic aneurysm, abdominal aortic aneurysm is defined as pathological dilatation of the aorta. It can occur in thoracic aorta, abdominal aorta, and thoraco-abdominal positions. Abdominal aorta and thoraco-abdominal. The cases included in this series are all abdominal aneurysms below the renal artery. Are all abdominal aneurysms below the renal artery. Aortic aneurysm, once a rare condition in 1980s, is not so uncommon today. In my practice, I would say that I used to see 2 to 3 patients every year during the time of 1980s and 1990s. But from the OPD room to the operating room, there were many dropouts, either refusing surgery or they would go elsewhere. This series of 19 cases were all done in major hospitals and does not include those done in smaller nursing homes. It does not include thoracic aneurysms and dissecting aneurysm, because that by itself is a very vast subject. What are the symptoms? Few patients are asymptomatic. Some patients may not have any symptoms at all. And how do they come to the doctors? They may have come to the doctors for some other complaints like gallbladder disease, gastric problems, or for checkup for cardiac conditions, or checkup for hypertension. The second one is abdominal pain. Abdominal pain and backache may be the presenting symptoms in few people. When there is a severe abdominal pain, it may indicate pre-rupture and requires immediate attention. When a patient presents with abdominal pain, tenderness, and hypotension, and it's a grave situation, and requires emergency surgery, indicates either a link or indicates either a link. The diagnostic tools available: X-ray of the abdomen, abdominal X-ray of the sonography, CT angio, MRI angio, and conventional aortogram. Simple test, simple X-ray of the abdomen. Simple X-ray of the show dilated aorta with calcified plaques. The diagnosis can be confirmed by abdominal ultrasound scan. More details can be obtained by CT angio or MR angio, and conventional aortogram is not recommended. And if it has to be done, it should be done by transbrachial approach. We are happy with the CT angio as it gives all the information that is required. Surgical approach is just like the other one already explained: midline, liberal, incision, laparotomy. Obtain proximal control at the level of the renal vein and distal control at the bifurcation of the aorta, or common iliac artery, depending on the disease, extension of the disease. After obtaining proximal and distal control, of the aorta, aorta is opened in the entire length of the aneurysm and remove all the clots, debris, to expose the neck of the aneurysm and also the bottom part, the distal part of the abdominal aorta. Once the area is cleaned up, we put tubular graft, anastomosis, proximally as well as distally. Few lumbar arteries that bleed in the posterior part of the aneurysm should be sutured, otherwise they may bleed postoperatively. After the graft is sutured to both ends, the graft is enclosed with an aneurysmal flaps, so the graft is completely covered. There were 4 cases of ruptured aneurysm. In 2, patients with rupture on laparotomy showed massive large retroperitoneal clots, and the third one was a rupture with 300 cc of blood in the peritoneal cavity. In these type of cases, the first thing to do is to get the proximal control as quickly as possible and proceed for the surgery that will be for the insertion of the graft, suitable graft. The 4th patient came in late night with hypotension, hemoglobin of 5 grams. On the opening of the abdomen, about 2 liters of free blood was found. Because of the prolonged hypertension, patient developed renal failure, cardiac failure, and multiple organ failures, and died on the 3rd day. What are the challenges? The challenges during the era of 1980 and 1990s were total lack of diagnostic facilities. Some of you may be surprised to know that there were no CT scan, no MRI angios, no conventional angiography, not even abdominal ultrasound facilities in most of the hospitals in Bangalore. Those days, aortic occlusive disease was diagnosed by abscess of lower limb pulsations, and abdominal aortic aneurysm was diagnosed by palpation of pulsating mass. Calcified plaques seen in the abdominal X-ray was useful. The second was poor ICU facilities in most of the hospitals in Bangalore, poor cardiology and pulmonary support. Many hospitals did not have monitors, ventilators, or blood gas facilities, and difficulty in getting adequate amount of blood products like platelets and FFP, particularly when the operation was scheduled as an emergency in the midnight. The patients with the rupture, pre-rupture of the aneurysm faced big challenges, especially when they are admitted in smaller hospitals and when they are admitted at nights. Thankfully, today, we have much better facilities in Bangalore. Challenges to the surgeon are only technical issues. There are many of these technical issues. There is no time to describe because of lack of time, I'm just choosing one issue. The issue is when the disease extends proximally up to the renal arteries, making it difficult to get proximal control. I had 5 such cases. Out of these, 3 were dealt with the endarterectomy. The procedure is same, laparotomy, get a proximal control and distal control. And these aorta are totally like a tire. They are totally diseased, no pulsations from the renal artery down. So what I do is I put a clamp, the cross clamp below the renal veins, make an aortotomy and start digging into it, remove the core. It takes quite some time to do it, a little bit at a time. And then you have almost like a well situation in the aorta, and then go cranialwards using some instruments like nibblers, upcutters, Fogarty catheters, Foley catheters, and mastoid dissectors. And this takes a bit of time. One has to do it piecemeal, slowly and steadily, till suddenly you will find gush of blood when the last bit of disease portion was removed. When this happens, let the blood flow a little bit so that all the clots will come out, and then put the cross clamp. And the rest of the operation is just like the other one which I described, end to side anastomosis of the graft, proximal graft, and the anastomosis is done to the iliac arteries distally. The second case that I have here out of the 5, the one was division of the renal vein. This was very tempting because the disease was right behind up to the renal vein. That means you cannot do a control below the renal veins. So what I did at that time was divided the renal vein. It gave us 1 inch more cuff for proximal control. And my idea was, after putting the graft, to bring the 2 ends of the veins and anastomose. Unfortunately, after putting the graft, we found that there's no space to bring the 2 ends. And while doing this, there was some bleeding occurred. So finally, they decided to ligate the renal vein. Fortunately, there is no artifact. This procedure has been done, and you can see in the literature being done. But only thing is, you have to see before you do this whether there are enough collaterals around the left kidney. The third was interesting case, thoracoabdominal approach. This was a 48 years old patient, came to the institution where I was doing only cardiac work, and the vascular department invited a senior vascular surgeon from UK to do aortofemoral bypass. I believe I wasn't there at that time. The laparotomy was done, and they found it's inoperable to do it, and they closed it. 1 year down the line, the same patient came to me with a gangrene of the big toe. Study showed that the blockage right the renal artery. The same thing I was describing right now. Now, since he has already gone to the abdominal approach, I didn't want to do that. So what I did was, I did a thoracoabdominal approach, a long incision through the 8 intercostal space in the chest, bringing down to the abdomen. The chest was open, and the tubular graft, the proximal end of the tubular graft was anastomosed to the descending thoracic aorta, end to side, and it brought it to the abdomen, to the retroperitoneum, making a small opening in the diaphragm as well, and mobilizing a little bit of spleen, stomach, and the colon. And this tubular graft was brought to the upper abdomen. There, I took up another Y graft, sutured it end to end, and the 2 ends of the Y graft brought down to the iliac artery and anastomose. It worked like a charm. Patient, as a matter of fact, who had a gangrene of the toe, didn't have to have a total amputation, got away with a small partial amputation of the toe. Aortic surgery in general, in experienced hands, gives good and gratifying results. Few patients are real challenge to the surgeon, like the ones I just described, and those with the leaking and ruptured aneurysms. Early diagnosis, early surgery with a good teamwork and team effort can save the life. Thank you.
It's a great honor for Surgical Society Bangalore to appreciate your contribution, sir, to the society as a cardiothoracic surgeon. I request all the members of Surgical Society Bangalore applaud sir contribution and felicitate on this day. Great. You should say, one with that.
Congratulations, sir.
Thank you, Venkat.
We have all got tremendous opportunities to work with Dr. Ganesh Nayak, sir. Very, very difficult cases we have done together. Everybody, he was everybody's vascular surgeon and cardiac surgeon for many years. May you continue all the good work that you have done for many more years, sir.
Thank you, Venkat. I had the pleasure of doing the surgery with you also in SCG. I hope you remember.
Sir. Yes, sir, very much, sir.
Yes.
We did many cases together.
Yes, sir. Thank you so much.
Thanks, sir. Thank you very much.
I take this opportunity to thank all our faculties, moderators for this first step program of the CSEP. And I thank all the members of Surgical Society Bangalore and our technical team to making this program most successful. Thank you, Ananda. We will tomorrow again we are starting the program online. It is at 5 o'clock with a case presentation. So the main highlight of the tomorrow program is Millennium Gold Medal Awards. We have 4 papers for that. After the case discussion, we are holding the Millennium Gold Medal Award. So kindly do attend in a good numbers. Thank you.
Thank you. Thank all the faculties, please, Harish. Thank all the faculties.
I thanked all our faculties and moderators so for their involvement. And as the case discussion was as it is like a physical discussion, so you made it more interactive. So thank you all the faculties and the moderators.
Tomorrow, so login time is 4:45 p.m.
Yeah.
Okay.
Yeah. Thank you.
Good job, Harish. Thanks
Thank
all
you.
the moderators and faculty. Good night, everybody.
Thank you. I know we work together.